Internal medicine makes up more than 50% of step 2, which means your IM performance directly determines your residency match. While average students memorize isolated facts, high scores master core concepts and apply them to see patterns linking symptoms to diagnoses. In this video, you'll see me work through questions from our program itself, breaking down the pathophysiology and turning IM into your greatest opportunity for score boosts.
One of the ways to reinforce information is to go back and talk about previous concepts. That way you can, again, reinforce it and learn how to use it. I want to go back to our discussion of resistors in series and parallel, because I think that this is actually a really useful concept that can be applied to both step 1 and step 2 questions to help you predict what the answers will be. If you model blood vessels like resistors in series versus in parallel, so series would be this, parallel would be this, right? The series means I have no choice. I have to go from basically one resistor to the next, versus parallel, if I'm an electron, I have essentially a choice, or there's a number of different options of which resistor I would go through. Danielle, can you tell us what's the total resistance equal to for resistors in series?
Resistors in series would be like R1 plus R2 plus R3 plus R4 equals R total.
Perfect. Deb, can you tell us, if I removed a resistor in series, what would the total resistance be?
Is to subtract the resistance in the resistor.
Yeah, perfect. One of the resistors in series, total resistance should go down. That's pretty straightforward. Hadra, can you tell us, for resistors in parallel, what's the total resistance equal to?
Yeah, for parallel, it's at 1 over total resistance equals 1 over R1 plus 1 over R2 plus 1 over R3.
Boom, great. Hadra, can you tell us then, based on that equation, if I removed a resistor in parallel, what would the total resistance be?
That would increase the total resistance.
Okay, this is critical. This is what makes it so useful from the standpoint of modeling it physiologically. In other words, if I remove, unlike a series, where if I remove a resistor in series, where I reduce the total resistance, in parallel, if I remove a resistor in parallel, I am now going to increase the total resistance. That's just a brief reminder of this concept. Now I want to actually go through some applications of this.
If you're serious about maximizing your scores, join our 14-day mini course now. We'll send you 14 high-yield videos that break down the exact concepts and test strategies our students use for 260 plus scores. Click the link in the description below now to get instant access.
Joyce, can you walk us through, and can you tell us, what would be the afterload and the left ventricular cardiac output be relative to normal if someone had a PDA, and why?
Patent ductus arteriosus is an abnormal pathway in between that of the left and right atrium. Is that correct?
PDA is actually between the aorta and the pulmonic artery.
It's between pulmonary artery and aortic. The cardiac output would be great.
Okay, why? How about the afterload?
The afterload would be less.
Great, why? How would you model it? I don't care that you get the right answer. I care that you understand how to apply the concept.
Yeah, that was a system 1 answer. Let's see. The cardiac output is...
Let's take a step back. Think about this in terms of resistors in series versus in parallel. If I've essentially added a conduit from my aorta, now there's an extra path. Would you model that as removing or adding a resistor? And would that resistor be in parallel or in series?
That would be in parallel, which means it reduced the total resistance.
Perfect. And if I reduce my resistance, so think back to, again, if I was going to make a tattoo, this would be the crux of my tattoo. HAP equals cardiac output times DPR, which really is just pressure is flow times resistance. Another way of thinking about that. What would then my cardiac output be relative to normal if I had a PDA?
Cardiac output would be...
Cardiac output would be increased. Yeah. In other words, if my resistance goes down, my cardiac output would go up. Perfect. Again, the concept is very applicable. If I add a resistor in parallel, my afterload goes down, which means in response, my cardiac output should go up. Cool. Does that make sense?
Yes.
Perfect. Well done. If I closed a VSD, what would be the afterload effect and what would be the left ventricular cardiac output effect relative to before I closed it? And what do you think, Ariel? If I closed a VSD, what would happen?
If you close, wouldn't that go back to what it normally should be?
Sure. Again, I don't care that you get the answer. I care that you use the concept. So the hardest thing to do early on is to train yourself to use the concept, because the natural tendency is to try to just like put Joyce into the beginning, like just say what you think is probably going to be the right answer. Again, like that, you can get some questions right just through like sheer logic, but I'd rather that you learn how to apply this concept, because this concept is actually very broadly applicable, the concept of resistors in series versus parallel.
Okay.
Ultimately, what I want to train you to do is to see the concept behind the questions. Because I think what a lot of people struggle with is they see a question like this and they're like, oh my God, I never knew, I never saw in first aid what would happen to the afterload if I closed a VSD. And then they panic. Yeah, exactly. But really, it's just a concept. There's one concept and there's, I don't know, maybe 10 different ways that they could ask it. But this is the same thing. Again, like you'll see every single one of these things has literally the exact same concept. And instead of trying to think of that specific VSD, the VSD part, honestly, it's essentially irrelevant. It's the concept that matters.
Assuming by what you're saying with the closure of the VSD being something in comparison to this resistance, I would say that we're taking away a resistance and this is in parallel. If that were the case, then that you would increase your resistance would then increase. That means that your afterload would increase. Your cardiac output would decrease.
See?
Awesome. That's actually really awesome.
Pretty cool. In other words, completely different from the typical approach, right? The typical approach is to look at a question like this and be like, I don't know. This wasn't in first aid. You will never ask me that. But instead, the key thing that you have to learn once you start getting the pathophysiologic chronology down, the next step is to figure out what's the standalone question. In other words, what really are they asking me? This question isn't really asking you about the closure of a VSD. This question is asking, do you understand how to model the blood vessels as resistors in parallel versus in series? That was very good. Nice, well done. Martina, you are up next. Martina, can you tell us, if I've removed the left kidney, what would be the afterload and the left ventricular cardiac output relative to normal?
Left kidney.
Again, does it matter that I'm asking you the left kidney? No. How should we think about this?
First, whether it is in series or if it is in parallel.
Yes, exactly. Yeah. What do you think?
This is in parallel.
Yeah. And why is it in parallel? Explain to me, why would it make sense to model the kidneys or a kidney as being in parallel with the rest of the system?
Because it goes in loops. It's not set on the same plane. Like,
yeah. So in other words, if I'm like, if my choice is, if I'm trying to get to my abdominal aorta, I have to go through my thoracic aorta. Those are in series, right? But if I'm in aorta to begin with, I actually want to continue down it, or do I want to go down my left renal artery?
yes.
Great. If it's in parallel, if I remove my left kidney, what would be the effects?
Total resistance would increase. That decreases your cardiac output and your afterload will increase.
Yeah, that's awesome. Yeah, well done. Just remember, guys, like one of my favorite quotes of all time was the Marcel Proust quote. The true process of discovery isn't in seeing new lands, but instead of having new eyes. When you learn a new concept, this is why before, when we talked about how to improve your system 1, a lot of it just comes down to training yourself to see these problems as the concepts underneath them.
I think it takes a little bit of practice, but it's very good to see it this way.
Totally. Yeah. But you hit the nail on the head. It's really just practice. Because I think people think, oh, I'm not smart enough. No, it's not. It's just, you just have to do it. And you do it enough. Like what we were saying before, I hope you guys have been, every time you stand up, thinking about venous pulling in your legs, decrease in left ventricular preload, which ultimately leads to a decrease in cardiac output, decrease in MAP, and then walking through the baroreceptor reflex to compensate.
Yes.
My guess is that when you've done that, the more that you do that, the more that now when you see a patient who is hypotensive and tachycardic, you just know intuitively what that means. In other words, you can see the concept without even really thinking about it. That's my goal with this. Again, the tendency when you do a question like this is to try to just like answer it based off of logic and not use the concept. And you will get some questions right. The problem is that you're robbing yourself of the larger opportunity to actually see these things with new eyes, to use the resistors in series versus in parallel to actually understand and predict the answers to all of these problems.
Yeah, I've never done this before. This using a basic concept which you've learned in school and then try to put it in here. And
yeah, but you use it. I remember when I was a resident at MGH, there was this visiting student, I don't know from where, but I wanted to go to Harvard for surgery. And he was like, you could tell he was trying really hard to impress them. And we were doing like a pneumonectomy. And so you have to clamp the pulmonary artery. They were asking him all these questions about EQ, and he was just totally following it. He just had no idea. They're very simple concepts. They're very very simple question. Again, like they're not hard. You just have to do it. That was good. That was awesome. Nicole, if I made an AV fistula, what would the afterload and the left ventricular cardiac output be relative to prior to making it, prior to creation? That's really what that should say.
I'm an AV fistula. Would this be like adding something in series?
First of all, let's start with what is an AV fistula?
It's just a connection between an artery and a vein that shouldn't be there.
Yeah, great. In other words, it's like a PDA, essentially, except that I made it instead of it was there to help my fetal circulation.
Then it would be more like it in parallel.
You tell me. You reason through it and tell me which would make more sense.
If I have a connection where more blood is going from my artery to my vein, I feel like that would decrease
Again, I want you to think about, you can use logic, but that should be your secondary check. I want you to apply this concept first. Again, is this more like a series where I have literally no choice? I have to go through these resistors in sequence? Or is it more like parallel where there's going to be a branch point and I essentially have a choice of which direction I go as blood?
I think it's going to be in parallel because you can go either through the artery, continue through the artery, or go through the fistula, correct?
Yeah, exactly. Great. So in other words, am I adding or am I subtracting a resistor in series or in parallel?
You're adding in parallel.
Great. Now it should be relatively straightforward. What effect will I have in my afterload and my left ventricular cardiac output?
If you're adding in parallel, then your resistance will decrease and your cardiac output is going to increase and your afterload is going to decrease.
Perfect. Yeah, exactly. Resistance, afterload, essentially. They're technically different, but they're essentially the same thing. Like for our purposes, they're essentially the same thing. But yeah, that was awesome. That was great. Nice. Remember this concept. Again, now every time you like blood vessels, I want you to think about them as just resistors and think of them, are they in series? Are they in parallel? Because there's a lot of questions for which this has a lot of relevance. Like PE is probably the most obvious one. What's the systemic resistance if you take out a kidney? These are very real questions. What if I clamp the pulmonary artery in an emenectomy? These are real. They help a lot. Yeah, this concept, again, these are your new eyes with which I want you to see problems dealing with blood vessels. Now we're going to switch back to vignettes. Nitya, what I'm going to do, I'm going to mix this up a little bit. What I'm going to do is I'm going to have all of you guys read the vignette. And I want you to come up with the pathophysiologic chronology. I will choose one of you at random to go through the pathophysiologic chronology. All of you guys are eligible. Read through the vignette and tell me what the pathophysiologic chronology is. Can you walk us through the pathophysiologic chronology?
Yes, so we have a 63-year-old man who comes to the physician because of fainting episodes.
That's not a pathophysiologic chronology. I can tell you that from the start. Anytime you're just going in the order that they're telling you, because remember, like these vignettes are in the typical order of an H&P. The first sentence is the chief complaint. That's usually the end of your pathophysiologic chronology. What happened first?
We have a healthy man who started to develop fainting episodes since 2 months.
No. Let's give someone else a shot. I think that is, again, that's not, going sentence by sentence analysis is not a pathophysiologic chronology. Let's go with Hadra. Do you want to give it a shot?
Yeah, I can try. Yeah, first we have to arrange the vignette according to what happened first. A 63-year-old man was born healthy, and then he had a poor lifestyle, and he acquired hypertension and diabetes, and which was poorly controlled. And then he develops, from the past 2 months, he has episodes of fainting and easy fatigability. And that fainting has been...
Yeah, but what's the pathophysiology, right? You have to tell me why. You can't just tell me the symptom.
Because of his poorly controlled hypertension and diabetes mellitus, I think he started having autonomic neuropathy. And because of that, I think he does not have the baroreceptor reflex to give him he gets hypertensive when he gets up. And I think the hypotension is causing him the fainting episodes for the past 2 months.
That's not a bad thought. It's not.
Yeah.
There's evidence that that's not the case.
A second thought as well. Yeah. And the second thing which I was thinking about, that because of his poorly controlled hypertension and diabetes mellitus, he's getting some kind of ischemic cardiac myopathy, and that is causing him the cardiac output to decrease and the map decrease.
No, that's not it either. Someone else want to give it a shot? This is a hard one. This is actually one of the hardest ones I think I wrote because it's pretty complicated. All right, I will share it with you. What's interesting about this is that no one talked about his EKG. I'm going to guess it's because you guys probably didn't make sense of it. And this is pretty common. They call this confirmation bias or anchoring. In other words, we anchor on a particular diagnosis. We think like, or system 1 says, oh yeah, long-standing diabetes, certainly diabetes could give you syncopal episodes because of autonomic dysfunction. That makes total sense. And yeah, that makes total sense. The problem is that the EKG doesn't fit with that, nor does the EKG fit with the idea of ischemic cardiomyopathy, both of which could explain fainting episodes, both of which are very reasonable hypotheses. The problem is EKG doesn't fit with that. And so what ends up happening is that, we kind of like just completely gloss over the EKG. Again, you call that confirmation bias because you ignore the evidence that goes against what we're thinking, and we only look for the evidence that shows it. Yeah, the other thing is to think about what causes syncope. And again, because the key is why his ventricular rate is much lower than his atrial. The summary of the pathophysiologic chronology, because again, there is the question of how in detail would you do this during an actual timed question, like on your test, versus how would you do this if you had more time to think it through? If I was doing this on a test, this is what I would have thought. RCA, MI, the right coronary artery, supplies the AV node. In other words, if I have ischemia to my AV node, then guess what? I may not get conduction from the atria to my ventricles. That would cause ventricular bradycardia. And really, the ventricle is the one that sets your heart rate, your pulse. If that's really low, then my heart rate's going to fall, my cardiac output's going to fall, I'm going to be hypertensive, and that's going to lead to syncope. We'll go through in detail what this would be later. But again, if I was doing this quickly, once I've reviewed this pathophysiologic chronology again and again, this is all I would need to do on a test to check to see if that made sense. Let's start by talking about syncope. Priya, can you tell us what's the general or the usual general mechanism of syncope?
Vasovagal syncope.
That's a little bit too specific. What's the mechanism? What's the underlying cause?
I think the blood pressure falls.
Yeah, that's it. That's pretty much it.
Yeah.
Global hypoperfusion of the brain because of hypotension.
Yeah.
Technically, you can have hypoxemia. There are less common cause, but I'd say 95% of the time, syncope is going to be because of hypotension, some form of hypotension. Like vasovagal syncope is a hypotension because your vagal stimulus is too strong, you get really bradycardic, your cardiac output drops. As your cardiac output drops, your MAP drops, your perfusion pressure drops. And Pooja, what equation can you use to explain this? Why hypotension would cause syncope?
I think is it MAP minus ICP?
Equals what?
The cerebral perfusion.
Pressure. Very good. MAP minus ICP equals cerebral pressure. If my MAP goes down, my cerebral perfusion pressure goes down, my brain hyperperfusion goes down, I have syncope. Again, you want to make that your eyes though. You don't want it to be this thing where it's like digging into the deep recesses of your memory, trying to hopefully find it, right? You want to make this your eyes. When you see someone that's lightheaded, or if I stand up, right? Sometimes I get lightheaded, or my wife recently was like, oh, I stand up quickly, I get lightheaded. I was like, oh, wow. I literally thought of the cerebral perfusion pressure, and then thought about what are the reasons why her mapping. So I don't know, she dehydrated all this stuff. But this becomes natural the more that you use it. Just like using the resistors in series versus parallel can help you to explain the blood pressure and the afterload in tons of different situations where you have either abnormal connections between vessels or decrease in abnormal connections. Let's talk about heart block. So Tridev, starting again, this is bolded. This is going to be a question that you're going to want to make cards on. We'll make the cards for you afterwards. But again, this is one of those key concepts that you want to make automatic. Tridev, can you walk us through, starting with the SA node, what's the order of depolarization of the heart?
From the sinoatrial, the impulse goes to all the atria, and from there it goes to the AV node, from the AV node to the bundle of Hayes, and then Purkinje fibers, then left bundle branch, and then right bundle branch, and then ventricle depolarizes.
Yeah, perfect. In other words, SA node to atria, to AV node to Purkinje fibers, to both ventricles simultaneously. Perfect. Allison, what exactly does it mean? It's embarrassing. I didn't really understand. I didn't really make sense of this until I was like an intern. But what exactly does it mean when we say that there's a sinus rhythm?
I think it means that there's a P wave before every QRS.
That's how you determine that that's like a way to tell you that there is sinus rhythm. But what exactly does it mean? Because that was kind of what I memorized as a medical student.
Oh, P. That's what we're told, and that's what I mean. Sinus.
What does rhythm mean? I never thought about that as a medical student.
Yeah.
Let me tell you. Basically, it just means that the electrical depolarization of the heart originates in the SA node. It makes sense why the thing that we all memorize, there's a P before every QRS and a QRS after every P. It makes sense why, because again, you're saying that like the atria are depolarizing before the ventricles. That makes sense. Technically, you could not be in sinus and still have that be true. But if you had an ectopic focus in your atria that was going off, It'd be kind of hard to tell, but yeah, generally we still assume that it's sinus in that case. Danielle, what does it mean to have third-degree heart block?
That means that the AB and SA node are beating independently of each other or conducting independently of each other.
Kind of. And that's not really the SA and the AV nodes. Think about what are exactly your independent.
Oh, sorry. The not the nodes. The like the atria and the ventricles.
Perfect. Yeah, exactly. Yeah. In other words, like your AV node is not functioning. Your AV node is like the one electrical connection between the atria and the ventricles. Kind of cool like that, right? You have this one sort of like bundle of electrical tissue that is the sole connection between the atria and the ventricles. And you slow it down. It's really slow through that AV node in order to allow time for the ventricles to fill after the atria is contracted. Cool. But basically, it also makes it like susceptible to damage or to problems. What happens in third-degree AP block is that the atria and the ventricles are beating independently of each other. That's what was happening in the case of our guy in this vignette. The AV node doesn't conduct signals between the atria and the ventricles, and it's usually because of ischemia. Deb, basically what that means is that the AV node is out, right? The SC node is going, so that's beating the atria, and then basically the ventricles are then depolarizing, but they are independent of each other. And as we'll see, the ventricles beat at a much slower rate, which is problematic for your cardiac output. Your atrial heart rate is determined by the SA node, and the ventricular heart rate is going to be set by the ventricular intrinsic pacemakers, which are a lot slower. Deb, can you tell us, if I were to remove the SA node, would the heart stop beating? Why or why not?
I guess the heart would not stop beating because there are still other firing points like AV node and even the Purkinje fibers or his Purkinje, the his Purkinje system or even the ventricles, but it just would not go through the normal transduction pathway because the firing would not like delayed in the atrium or delayed in the AV node because the AV node.
Yeah, perfect. So in other words, it's not ideal, but yeah, the heart would still continue to beat. Kind of cool. There's a backup system. If the original pacemaker on my SA node stops working, I have other pacemakers. The rhythm, instead of it being sinus, now the rhythm is going to originate in other parts of the heart. Excellent. Hadra, what's the order of the parts of the heart that would take over pacing if I remove the SA node, and why?
If we remove the SA node, the AV node would take over the rhythm next. And then if we also remove the AV node, the ventricles themselves would take over the rhythm.
Yeah. Actually, interestingly enough, the atria would take over first, and then the AV node.
Okay.
And then the ventricles. Yeah. There's a different sort of intrinsic rate of depolarization, which again is set by the phase 4, just like it is in the SA node. But typically, again, the faster thing takes over fast because you'll reach the threshold faster. Joyce, I just said this. What phase of depolarization would determine the pacemaker rate?
4.
Great. All right. Well, that was a gimme, so let's give you another one. Why would the atrium take over pacing of the heart first? If I remove the SA node, like why wouldn't it be the AV node?
I don't know.
Think about it. What determines who is going to reach depolarization first? The atria or the AV node, and why?
The atria, because the SA node is located in the atrium.
No. It all has to do with the phase 4 depolarization. In other words, remember the heart rate is determined by what aspect of the phase 4 depolarization?
The slope.
The slope, yeah. In other words, right, another way of thinking about the slope is how fast or how slowly do I reach the threshold at which the voltage-gated calcium channels are going to open? In other words, if my atria have which has a faster intrinsic rate, my atria or my ventricles?
The atria.
Great. What does that mean about the slope of their phase 4 depolarization?
Sharper, or it's faster than that of the ventricles.
Perfect. Yeah, exactly. So in other words, what is going to determine the pacing of my heart? Is it going to be my atria first, or is it going to be my ventricle?
So it would be the atria.
Yeah, exactly. They have the fastest slope. The atria is the fastest slope of their phase 4 depolarization, which means they're going to reach depolarization threshold first, which means if they start their action potential first, they're going to depolarize the rest of the heart before the other pacemakers have had the chance to reach their own threshold. Does that make sense?
Yes.
Perfect. Luis, why is third-degree heart blocks bad then?
Because the ventricles are going to be, or the ventricle myocytes are going to be contracting independent of the atrium rhythm. Therefore, the patient is going to be bradycardic since the ventricles have the slowest slope phase 4 to reach the threshold. So the patient is going to be bradycardic and possibly symptomatic.
Very good. Yeah, almost usually symptomatic. I don't want to say always. Good. Why are they beating independently?
Because the AV node is not going to receive all the electrical stimulus from the atrium because of the dissociation between the atrium and the ventricles. And the block is basically in the AV node. The ventricles will be independent from the sinus rhythm.
Perfect. Yeah, exactly. My guess is that a lot of you guys hadn't really thought about like why is I hadn't at your stage really thought about why is hypertrophy heart blocks bad. Wasn't it until probably late med school, early residency where it really hit me. I was like, oh, you have ventricular bradycardia. Oh, that's going to be really bad for your cardiac output. But again, I want you to correct my mistakes. I want you to start thinking about these concepts sooner and applying them, using them as your eyes to see literally the same landscapes, but in a new way. That's the key to getting these questions, is to be able to recognize the concepts behind them. That's true for step 1 questions. That's true for shelf questions. That's true for step 2 questions. Louise, that was awesome. That was great. The ventricular intrinsic rate of depolarization is super slow. Yeah, exactly. Because your heart rate, and that's basically determining your heart rate. That's awesome. Great. Marielle, what is the pulse of this person? If you were to feel their pulse, what would it feel like and why?
It looks erratic.
Yeah, what are we looking at? This is something they could share in your test. Particularly subject, but even step 1. Can someone walk us through? What are we looking at? Yeah, what are we looking at? First time I saw this, I was like, what? And then when someone points it out, you're like, oh yeah, you want to give it a shot?
Yeah, can I ask you, you are asking about the heart rate?
The pulse. I'm asking for the pulse.
I'm not sure that I'm saying is right or wrong, but I'll try. Basically, I think we try to determine the RR intervals, like between how many blocks it comes.
Yeah.
And then from there, if there are almost there are 7 blocks are coming between them, yeah, we'll divide 300 by 7 and we'll get 42 something.
Perfect. Yeah. In other words, super low. Let me point out the key elements of this, because again, it's like one of those like magic eye puzzles. Like once you see it, you're like, you can't unsee it. But until you see it, you're like, what the heck is this? These are the P waves. This is a P wave. This is a P wave. This is a P wave. You can see there should be a P wave here, right? You see, it's basically a P that's buried underneath a T. It looks funny, but this should be a P wave. This is a P wave. There's presumably a P wave here. The QRS looks a little more funky. This sort of whip is probably the part of where the P wave is. P wave, wave, P wave, P wave, P wave, P wave, P wave, P wave. Now, in other words, the P wave intervals, if we think about this, as Jadev was saying, as 300 divided by the number of big boxes, it's 1 big box to 3 big boxes, maybe around 100. 1, 2, 3, yeah. Pretty fast atrial rhythm. But if you look at the QRS intervals, this is QRS, 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 this is QRS. This is third-degree heart block, because you can see the atria are the P waves are progressing, or I guess here. That has its own intrinsic rate, and the QRSs have their own intrinsic rate. Pretty cool. Yeah, you can do 300 divided by the big boxes, but yeah, the atrial rate's about 100. There's about 7 boxes between QRSs and ventricular rates, which again fits. The atrial rate's a little high. Presumably that's because this patient's probably hypotensive. Their sympathetic tone's probably very high. I wouldn't be surprised if they were essentially tachycardic, right? They have atrial tachycardia, but their ventricle's not. Makes sense. Why the atrial rate would be that high. Cool. Does that make sense to you guys? Interestingly, I actually had a student once who had third-degree heart block. I was like, no, that's no way. You're like, where's your pacemaker? But apparently she didn't have it. She's like the first person I've ever met who has third-degree heart block that did not have a pacemaker. Because typically the treatment for a third-degree heart block, or even Mobitz to second-degree heart block, is to have a pacemaker. Because again, you will become if your heart rate suddenly dropped to the 40s and you couldn't augment it, like when you stand up or any other time that you would need to augment your cardiac output, that's going to be a problem. Nice. Martina, why are the atrial and ventricular rates different in third-degree heart block?
Because they are beating independent of each other.
Perfect. Sure. But what explains such a big difference in their rates then? Because beating independent doesn't necessarily mean that the rates would have to be different, but why are they different?
The conducting system in the atria is faster and smaller than the one in the ventricles.
Yeah. The intrinsic pacemaker rate Yeah. The atria, they're driven by their intrinsic rates rather than being all driven by the SA node. The SA node drives the atria, the ventricular rate is going to drive the ventricles. Why then, Nicole, would someone have syncope with third degree heart block?
My guess is because the atria and ventricles are not contracting like in an orderly fashion, that they're not getting enough cardiac output.
That's like, no. Again, I want you to use the concepts that you know in order to explain this. The next step is to figure out which concept to use. But when in doubt, in a cardiology question, you should always think about which equation.
MAP equals cardiac output times resistance.
Yeah, perfect. Or times TPR. Good. Which also equals what?
The heart rate times the stroke volume times TPR.
Perfect. Now tell me, why would someone have syncope with third degree heart block?
Because it is affecting their stroke volume.
It's actually not really. Their stroke volume actually would be pretty high in this case because they'd have a monster preload.
I'm not sure.
Why are the atrial and the ventricular rates different, Nicole?
Because they have different intrinsic rates between the atria and the ventricle.
So what's the ventricular intrinsic rate?
It's a lot slower than the atria.
Great. What determines my pulse? What determines so in that equation, MAP is cardiac output times TPR, which equals heart rate times stroke volume times TPR. What actually is determining that heart rate? Which rate are we talking about?
The ventricles.
Yeah, the ventricular rate. Now tell me, why would someone have syncope with third degree heart block?
Because they are relying on their ventricular rate, which is a lot slower. I'm not sure.
You're right.
So
what?
They're just not getting enough beats per minute. It's reducing their overall cardiac output.
You're asking it as a question. I get the impression that you're not thinking about MAP equals cardiac output and CPR every time you stand up. You have not made this a part of your thinking. This is just like something that you're recalling when asked on a test.
Okay.
You can do this, but I want you to tell it to me as an answer, not as a question.
I think that because they're relying on their intrinsic ventricular rate, their heart or their ventricles are beating at a slower pace, and there is less beats per minute and less cardiac output.
Which leads to what?
A decrease in MAP. Because they're not getting enough blood to the brain, there's cerebral perfusion. Yeah, the cerebral perfusion pressure equals MAP minus ICP. And when the MAP decreases, the cerebral perfusion pressure also decreases.
Boom. That was good.
Thank you.
Again, I want you to think about this in terms of, I want you to use this as a way to see the world. I really just like with the blood vessel thing, you can use this as like basically new eyes to see the world. Because again, almost all cardiac questions can come back to this, right? MAP is cardiac output times TPR, which equals heart rate times stroke volume times TPR. If my ventricular rate is only 40, if my heart rate suddenly drops to 40, really low, then my cardiac output's going to go low. My cardiac output's down, my MAP is down, my cerebral perfusion pressure is down, I'm going to get brain hyperperfusion. That's going to lead to syncope. Cool. Perfect. Nitya, what is the typical treatment for third degree heart block? And why? Why would that make sense?
No, I believe it would be a pacemaker. It would be a cardiac rhythm that we have the SA node.
Ooh, that's not the right answer. Why is that not the right answer? Think about it. That was like a system one answer, I think. If I paste my SA node, what am I going to do? What's the problem in third degree heart block?
The main problem lies in the ventricular rate being very slow.
If I paste my SA node, the main problem is that I don't have conduction between my atria and my ventricles. If I paste my SA node, what's going to happen?
That would create an independent rhythm which would be independent of the ventricular rhythm. So I think that would be wrong. I understand that. It should be pacing the ventricular rhythm now.
What does that mean to pace the ventricular rhythm?
Since we do not have any AV nodal conduction pathway, the main pacemaker of the heart at the present moment would be the ventricles. If we put a pacemaker at the level of the ventricles, it would perhaps increase the ventricular rate.
Yeah, exactly. It's just terminology. You wouldn't say that you would pace the ventricular rhythm. It just doesn't. I don't think that makes sense. You say you'd pace the ventricles. But yeah, that's right. Good. Yeah, you'd pace the ventricles. You'd artificially pace the ventricles so that you're no longer bradycardic. Good. Priya, what blood vessel supplies the SA and the AV nodes?
I think the circumflex.
So usually it's
Is it right coronary artery?
Yeah, usually it's large.
Sorry.
Yeah. Technically, you're right. Want to get really specific, it's about 60% of the time for this, about 90% of the time for the AV node. But for your test, for test purposes, it's like almost always going to be the RCA. But it's a pretty common thing. Pooja, what are the inferior leads of an EKG?
2-3 and AVF.
Boom. Yeah, 2-3 AVF. Good. Sebastian, what artery feeds the inferior part of the heart And what artery does this, at least typically, arise from?
The inferior part of the heart is going to be perfused by the posterior interventricular artery, and which a continuation of the right coronary artery.
In what kinds of people?
In right dominant.
Technically, it's only right dominant people. Yeah. The posterior descending, or as you called it, the posterior interventricular artery, is a branch of the RCA, at least in right dominant individuals. Good. But then again, this is, I'm telling you the classic case because this is pretty common to see. In a STEMI, an ST elevation MI involving leads 2, 3, and AVF, why might a patient have sinus bradycardia? Why would that make sense?
Right coronary artery is blocked, that's why, and because it's also supplying SA node. So if SA node will not function properly, then it will be sinus bradycardia.
Boom. Yeah, exactly. This is one of the really tricky questions that they'll give you sometimes on step 1 or step 2. And honestly, this is the kind of thing that you have to be aware of in clinical practice too. Whenever you see an inferior MI, you have to have your antennae go up and think, oh man, there may be a problem with some of the nodes, either the SA or the AV node. And yeah, you can get inappropriate bradycardia. This is a very real thing. Yeah. The inferior wall, remember, is fed by the posterior descending artery, which in right dominant patients arises from the right coronary. If I have an RCA thrombus, not only will I have an inferior MI, because if I'm right dominant, it'll affect my posterior descending artery, which feeds my inferior wall, but I can also get SA node ischemia, which can give me sinus bradycardia, dysfunction of my SA node. Awesome. Well done. Again, you'll notice this is bolded because, again, I want you to be able to learn to make these connections. The way to do it is to practice it when you're not in a test, when there's not time pressure, so that when you see it in a test, well, and then make a pathophysiologic chronology, start to see it in context. And then ultimately, when you're in your test, when you see, oh, inferior MI, someone has bradycardia, you can intuitively know what the connection is, as opposed to what most people do, which is see that, completely gloss over it, and then miss a large part of the question. Let's go back to Danielle. Danielle, would a lateral wall or an inferior infarct be more likely to be associated with third-degree heart block, and why?
I would think an inferior infarct because we just said that was since the right coronary artery supplies the SA node and AV node, but you would have the bradycardia of the third degree block. Since the right coronary artery is supplying the SA node and AV node, then an inferior wall MI is usually a blockage of the right coronary artery that would cause the disconnect and the electrical impulse to the ventricles at the SA node and AV node.
Yeah, the idea is that the RCA thrombus, assuming it's a right dominant individual, the RCA would give rise to the posterior interventricular, which would feed the inferior wall, but it also gives rise to branches that supply the AV node. So if the AV node gets ischemic, you can get third-degree heart block. Good. Deb, if I see ischemia in 2, 3, and AVF, what should I be concerned for? What kind of complications should I be concerned for? Again, you'll notice all these are bolded because, again, these are things that show up a lot in vignettes. I really want you to make cards on these. Deb, what do you think?
Ischemia in the inferior leads, which means that the posterior descending artery ischemia. The most concerned things would be the AV node, nodal dysfunction, which would lead to bradycardia or heart block. Yeah, and in the heart blocks, the third degree heart block would be the most serious ones, I guess.
Yeah, essentially, again, the RCA gives rise to both to the posterior descending artery, but also supplies usually supplies the SA and AV nodes. You can be concerned for right ventricular failure, which will give you isolated heart failure. It will give you SA node ischemia, which can give you sinus bradycardia, and it will give you AV node ischemia, which will give you third degree heart block. Yeah. Pooja just says she had a question on this. Can you share the question, or what was the context?
Oh, yeah, it was something with the guy coming in and they gave the EKG and he basically passed away. The question was, which of the following complications of an MI would also contribute to this patient's death? And they gave some microscopic examination results. And one of them was also papillary muscle rupture, was like cancer. And the patient had an MI, an inferior MI basically. And these were the things that like an inferior MI most likely predisposes to or something.
I see. Yeah, it's pretty common. I gotta say, like that using 2, 3, and AVF as a proxy for an RCA infarct is super common. And this shows up a lot. One of the ways we didn't discuss really much here, but one of the ways in which we'll talk about this in a sec, but one of the ways in which this can affect you is that if you get right heart failure, you have to be really worried about dropping their preload. Because if they go into right heart failure and then you decrease their preload, you're just going to make it worse. Like an inferior infarct is one of the times when you actually don't want to give nitrates, where you have to be really careful about giving nitrates because you can kill them, because you'll make them hypertensive, because you'll drop their preload too much. Because in right heart failure, you're like, say, preload dependent, because you need the right heart to get more preload so that you can get more blood to the left heart. But yeah, it's pretty common. But Hadra, in a right dominant individual, what would the pulmonary artery wedge pressure be if I had 2-3 in AVF, if I had an MI there?
The inferior part of the heart is affected. The right heart is affected, which means that it's like a right heart failure, and there will be backup of blood in the right heart, and the right heart will have a difficult time pushing the blood into the pulmonary arteries, and then the capillaries, and then the veins, and the left atrium. Left atrial pressure will decrease, which will decrease the pulmonary artery wedge pressure.
Boom. Yeah, exactly. Well done. Yeah, your wedge pressure is down. And the reason is because if you have a right-sided MI, you'll have right heart, you can have failure, your pulmonary flow is going to be down, your left atrial pressure is going to be down, which means your wedge pressure is going to be down. Nice. Well done. Now we're going to come back to the question. Again, we just went through the trouble of going through and explaining every single line basically in this question and why it makes sense. It takes a while. You'll notice that it takes a while to do this. However, now that we've done it, I want you to read the question again, and I want you to tell me, what is the pathophysiologic chronology? How can you make sense of this? I want you to take a little bit of time, and then I will call on someone at random, or you can volunteer. Martina.
This 63-year-old man was born normal, and he developed some sort of dietary and lifestyle changes which were not good for him, and he developed hypertension, and which he did not control, was not taking his medication as such, and he also developed diabetes mellitus. Both of these chronic conditions affected his arteries, and it caused some sort of inflammation, and because of that, it led to deposition of proteins, or there's arteriosclerosis, and that's what led to him having a block. And he had
Let's actually be clear. Technically, it's actually the atherosclerosis. Arteriosclerosis just means your arteries are hard. Athero is the plaque, is like the fatty. But it's actually atherosclerosis that would give you a heart attack. Just having stenosis in and of itself doesn't mean that you're going to have a heart attack. What actually leads to the heart attack?
It's the atherosclerosis. That's basically when he develops fatty streaks at a very young age, and that leads to deposition of
It feels like you memorized it.
cholesterol.
What exactly is the cause of the MI? What's different about an MI versus just before the MI?
The rupture of a
Yeah,
plaque,
very clear. Rupture of a plaque. The plaque ruptures, which causes what?
dislodgement of it causes the thrombus.
Exactly, right? So the fatty material has like tissue
Yes.
factor and other stuff in it, but essentially causes a big clot, a big thrombus. Great. Which causes what in this case?
It causes a block. A movement of the thrombus causes a block, becomes like an emboli and causes a block.
Again, it's not really an emboli. I used to think that. I used to think, oh, there's like a plaque rupture, and it's not, doesn't really. I think it's actually mainly like in situ. It's right where there's a clot. I used to think there was like, oh yeah, maybe it's like some rupture somewhere, and it like goes, maybe that happens a little bit, but really it's just, it ruptures and then boom, immediately there's like a clot.
It's like the rupture leads to an inflammatory process response, or
No, it's not inflammation. It's just
clot formation. Yeah. Because of that, he develops fainting episodes because there's decreased perfusion to that area of his heart because of the thrombus and the clot. Here it is the right side,
which causes what?
which causes him to have a decrease or a change in the R wave rate.
Why?
Because the ventricular rates are decreased.
But why?
Because the AV node is not functioning.
Why?
Because there's a block in the supply to the AV node.
Good. Because why? I'm asking this because this is the level of detail that I want you to think about this at.
No, I really appreciate it because I miss out all of this. It's because the right coronary artery gets blocked.
Yes. You had atherosclerosis in the right coronary. There was a plaque there. The plaque ruptured, which caused a thrombus. That thrombus caused ischemia to, you said, the AV node, which causes what?
decrease in the ventricular heart rate, the conduction.
But why? I mean, like, describe, what does that mean? So, like, what condition are we talking about here, though? Syndrome, right? Third degree heart block. Just got third degree heart block, which leads to what?
He has a decrease in his blood pressure.
Why? Again, that was really good. That was really hard to do, really hard to do. What I want you to work on, though, is I want you to, you mentioned, Martina, earlier that it's really hard to make these like really small detailed connections. I want you to go through these vignettes and I want you to look at all of these connections. You can use them. I've already made them for you. And same thing with the mentors. They've given you these connections. They've made them for you. And I want you to make more of these concepts automatic. Because I get the sense that it's what I did, honestly. Like I memorized, fatty streaks are the first thing that you see. And there's this inflammatory process and there's macrophages, and muscle cells, and like blah, blah, blah. And I could drone on, but there was like no real understanding behind it on my end. When I listen to you talk about some of these things, I get that sense that you've memorized the words, but you don't really understand the concept behind them. The approach I want you to take, and this is true for all of you guys, is I want you to slow down and I want you to actually learn the concepts to the level that you can see the world with them. Use them as your new eyes to see the world. Because that was pretty good, but I think that the more that you do that, the faster you'll see these connections. Danielle, I want you to walk us through the end. Martina got us really far. Doesn't take good care of his body, develops diabetes, hypertension, atherosclerosis of the RCA, leads to a plaque that ultimately ruptures, that leads to a thrombus. Actually, let's do Joyce. Actually, I want you to tell us. So that leads to a thrombus in the RCA. Now, tell us, why does he have syncopal episodes?
The thrombus causes a decrease of blood supply to the right ventricle. Then you're decreasing stroke volume, which means you're decreasing cardiac output, which means you're decreasing.
That works, except that that's not what the EKG shows us. I mean, that could explain it, right?
Yeah.
Again, we're going to try and move past the confirmation bias and try to evaluate all evidence and see does it fit with our ideas.
The RCA also supplies blood to the AV node, and with the thrombus in the right coronary artery, you have ischemia in the AV node, which means then the heart uses the ventricular pace, which slows. And because of the ischemia to the AV node, the SA node and the AV node have independent rates. So the atria and the ventricles have independent rates.
So why would it be syncopal and be?
Right. The ventricular pace is slow. It's 20 to 40 beats per minute. And because the heart rate is slow, that means your cardiac output is low, which means your mean arterial pressure is low, and that results in decreased cerebral perfusion pressure.
Boom. Perfect. I can tell that you've made the last part pretty automatic, because that just flowed off your tongue. You're like, low, cardiac output low, map low, cerebral perfusion pressure. In other words, hopefully you've been practicing that, right? When you stand up, at least some of the time, hopefully, when you're on your psych rotations, you're thinking about cardiac physiology.
Yeah, definitely, yeah.
Yeah, hopefully. I can tell you're at least doing it some of the time. But I can also tell that this other stuff is new. You're like, yeah, something about the rates are different in the assay and the ventricle and right. In other words, now the key is to bring the new concepts up to snuff with the old ones. That's pretty good. That's pretty good. Does someone want to see if they can do that or do it faster? Walk us through. Right, give us try and predict what tell us what the summary statement is going to be.
Just a summary of the overall pathophysiologic chronology.
Yeah. If this were a timed test, if this were like your real test, how quickly and how the big picture stuff, how could you do it?
I would just say that with his hypertension and diabetes, it's poorly controlled. That predisposed him to cardiovascular disease. He developed an atherosclerotic plaque that ruptured, which developed into a thrombus in the RCA, and that decreased the blood flow to his AV node, and then he developed third-degree heart block, which resulted in the heart relying on the intrinsic ventricular pace, which decreased heart rate, decreased his blood pressure, and then decreased his cerebral perfusion pressure.
That's pretty good. That's maybe a little bit more than I would have given in my summary, but that was pretty,
okay.
It was still pretty fast. If I had given it, I probably would have said something like, honestly, I probably would have said RCA infarct, AV node ischemia, third-degree heart block, symptomatic bradycardia. You can tell I skipped a lot of steps, but because I've already gone through those steps in my head, I know that if I needed to, I could fill in the gaps. But again, in a time setting, you have to be practical. You can't sit there and, as much as I would love for every single time on your tests for you guys to go through heart rate is low, cardiac output's low, MAP is low. I recognize that you won't be able to do that for literally every single question. if you're doing an Anki card, you better believe that you should do that. But that was actually really good. I'm impressed. Yeah. I want to ask you, let's wrap up. I don't think we have time to do any more questions, but we can certainly wrap up. My goal with this is to show you what happens when you, A, master the concepts behind it, that you can start to see those concepts a little bit more automatically. And B, what happens when you make a pathophysiologic chronology, that when you see the question the second time or the third time or the fourth time, once you've made a card and you've repeated this a number of times, that it starts to just become more automatic. You start to see it and it's like those like magic eye puzzles. You can't not see it. I don't know, Nicole, what was your impression? Because that was pretty good, actually.
Just my impression of like the scenario.
Or of your ability to answer it, like of your ability to answer this, or like thinking to the future. If you were to do this more, how much would this, what would be the effect on your ability to interpret questions and get more questions right?
I definitely, obviously, it would help a lot more. I haven't really understood like the progression of atherosclerosis to essentially something like syncope as well as I do now. It was hard for me to make the connections at first, but once I made them, it seemed like it was pretty easy to see the whole picture of what was going on.
Yeah, I think that's generally true. How about other people? What are your impressions, or just overall impressions? Like, how does it feel to do this?
I think it really helps me to put abstract concepts together, because I think that in first aid, all of the concepts have their own little box, and this sort of ties all of them together instead of learning and memorizing them as individual things, to see it in the system. That I think makes it stick a lot better.
Yeah, totally. Yeah, there's very good evidence behind making abstract things concrete and concrete things abstract. I think there is a Department of Education study. They looked at basically like big picture, like they looked at what are the educational techniques that have the strongest evidence. That was one of the things that had the strongest. Yeah, makes total sense. Perfect. Other people?
It actually made me realize that I forgot the term you were using, what you were calling it, but I was thinking back to like when we first started this session, I was really stuck on the idea of poorly controlled hypertension. And then I was like immediately thinking left ventricular hypertrophy, or like, something along those lines, or how completely wrong I was. And then when, like you said, but it doesn't correlate with the EKG, and I was like, crap. Like, you're right. I completely do that, where I just need to like pull myself together and just read the whole thing. Thing that I need to really work on is what this made me realize.
That's good. I think the concept you're talking about is anchoring.
Yeah, there you go.
Anchor on a particular diagnosis. That's a really good point. Yeah, because our system one can also sort of like our intuition, right? Our intuitive answer can lead us down the wrong path too, and that happens a lot. Because oftentimes when you see poorly controlled hypertension, Marielle, you're right. Like controlled hypertension, you're thinking LVH, you're thinking apathy. It's really easy to anchor on that and to think, oh, maybe this is LVH. And then you're thinking, oh, that would actually explain syncope potentially. There are certainly ways that you can do that. The problem is that then we have the confirmation bias. And then then you ignore why are they bradycardia? Because LVH wouldn't explain bradycardia, certainly wouldn't explain symptomatic bradycardia. And then the EKG totally doesn't fit. It's really common. That's one of the things that I like about the pathophysiologic chronology, is because it forces you to make sense of all the sentences, and it helps you because then you're stuck trying to explain what like the EKG, like, oh, I can't do that. It becomes a lot more clear like when we're about to go down the wrong path or not, before we get to the end of the path and we realize, oh man, I have no idea what's going on. Other impressions? Hajra, how about you?
Yeah. When I was going through the question, I realized that I completely ignored the EKG, and I was just thinking about the rest of the scenario. I think if we keep on repeating these scenarios, similar scenarios on the test are going to look familiar, and I think we'll do better.
Yeah, totally. Yeah, because it's kind of in fairness, I set you up for this. In the past, I gave you literally, like, I think our first vignette was one where it was a guy with longstanding diabetes that had orthostatic, and it makes sense. You're like, yeah, it makes sense that you would latch onto that. The problem is that you have to have the flexibility to recognize when the scenarios vary. And I agree. I think if the more scenarios, my goal with this was to show you that there's lots of different scenarios that can lead to the same symptoms. And like a PE could lead to these symptoms. A right-sided MI can lead to these symptoms. Autonomic neuropathy can lead to these symptoms. Like a lot of things can give you hypertension, and particularly orthostatic hypertension. And being able to recognize that and knowing all of these different scenarios gives you more flexibility, gives you more lateral thinking that you can transfer between, as opposed to just seeing the buzzword like polyclinical controlled hypertension, anchoring on that, and then you're just stuck.
Initially, when we did these, there was a lot of emphasis on going like one sentence at a time and putting the pieces together. But in this scenario, I was trying to do that. And when I do that, I do get trapped in this, like you're saying, anchoring. And I do dig my heels into something that I'm thinking just based off of the first 2 or 3 sentences. By the time I get to the last sentence, like in this case would be the EKG, I would glaze over that almost, because in my mind, I already have a decision. Is it better to maybe read the entire scenario first before we sort of
That's a fantastic question. You're saying, if I think about every sentence, sometimes it leads me down the wrong path. Maybe I shouldn't think about every sentence, and I should just read everything first and then try to put it together at the end. The problem is that particularly for the longer the vignette, the harder that is to do. And oftentimes, I'm in the middle of writing a lesson on this, but basically, how you think of the first sentence affects how you think of every single other sentence after that. I guess what I would say is that the best thing that you can do is it's really how it is that you prepare before you go into the test that matters. It's like those coaches that say like championships are won in practice, or games are won in practice, not in the actual game itself. I look at question interpretation the same way. If you find yourself anchoring on one diagnosis and not being able to generate other ideas, it's not really a problem of how it is that you're thinking about the question at the time. It's really a problem with your preparation leading up to doing the question. In other words, the more pathophysiologic chronologies that you've generated, the more flexible your thinking will be. Where you are right now, I actually don't like doing sentence by sentence analysis, not doing sentence by sentence analysis. I think it matters much less than making sure that you can generate a clear pathophysiologic chronology where you can connect all the details. Because if you can do the latter, in other words, if you can generate the pathophysiologic chronology, it will be a lot easier to analyze the question the next time you see a similar question. Pooja, what are your thoughts?
I mean, like you just said, how you read the first sentence will affect how you read your second sentence and third sentence, and so on and so forth. So for me, as you can tell, like for the past few sessions that we've had with you or the other tutors, like this has been my biggest concern, because I do keep getting trapped into this where I read the first sentence, I think it's something, and by the end of the vignette, it's like completely something else, and I don't catch on to it because I'm still finding that first sentence.
Exactly. So I guess what I would say is that it's 2 parts. It's like we said in the first lesson, we're trying to improve your intuition. In other words, you're trying to train your system 1. That's why we're doing the pathophysiologic chronologies. In other words, if your first sentence, if your intuition was right, then everything else becomes a lot easier. That would be, in an ideal world, your first intuition is going to be right. But what you're asking is as well, it's not an ideal world. Sometimes my first intuition is sure, I'm working on training my first intuition, but what happens when my first intuition is wrong? That's where your system 2 comes in. You have to generate the pathophysiologic chronologies for every sentence as you're going. It has to fit. In other words, if you read the third sentence and it doesn't fit with the idea of LVH, then you need to change your story. You need to recognize then that you need to change your story. Because if you ignore the bradycardia and you keep going, that's now on you. Does that make sense?
Yeah, that makes sense.
It's a 2-part process. You have to improve your system 1. You have to train your intuition so that your gut instinct when you read a sentence is right more often. But then you also have to trust but verify. Think, yeah, my system 1 has told me that this is LVH, but also let's see if I can make that fit with the vitals. I can make that fit with the respirations and the blood pressure, but I actually can't make it fit with the pulse. Oh, I don't know, bradycardia, but bradycardia could certainly explain the low blood pressure. Maybe there's a reason that he's bradycardic. In other words, I'm starting to open my mind to other ideas. I'm not anchoring on one diagnosis. And then I read the next sentence and I'm like, oh, we have 3rd degree heart block here. That would totally explain the low pulse and the low blood pressure, and could also alternatively explain the fainting episodes because they would be syncopal from low cerebral perfusion.
When you read that first sentence about a 63-year-old male, blah, blah, are you thinking LVH at that point?
Oh gosh, no. No, all you know for fainting, again, is hypotension. I read the first sentence, I see hypotension. Second sentence, hypotension. Without warning, it tells you that it's cardiac, most likely. This is known as unheralded syncope. Unlike vasovagal syncope, where you're diaphoretic and get faint beforehand, there's no warning. Typically, you see that more in cardiac. I'm thinking something cardiac. And again, which fits with his age. Poorly controlled hypertension, diabetes mellitus. Again, I'm thinking cardiac risk factors. There's, again, I have a pretty open mind, though, because there's a lot of, as you saw, there's a lot of reasons why coronary disease could lead to hypotension. Pulse is low. Now it's pretty specific. It's either SA node ischemia or AV node ischemia, most likely, right? But in other words, I didn't anchor here. Part of this is learning to not anchor early on or to see a buzzword until I think something. But it's hard to do. I would say the easiest, the most straightforward thing to do at your stage is to make good pathophysiologic chronologies, because it'll give you more options. Because the difference when I read a question and I think when you're reading a question is that I have I could generate 5 or 6 ideas pretty quickly of how diabetes, hypertension could lead to syncope and exertional dyspnea or easy fatigability, right? Whereas because you don't have the pathophysiologic chronologic knowledge, it's a lot harder for you to generate them on the spot. You're kind of stuck, right? You go with the one thing that you like, I know LVH, this must be LVH, or, oh, I know autonomic neuropathy, this must be autonomic neuropathy. The difference is that I have many more pathophysiologic chronologies at my fingertips this week. I just have more experience. But again, the question is, how can you gain that? The way to gain that is to do more pathophysiologic chronologies. Does that make sense?
Yes, thank you.
So what we're going to do is I'm actually going to give you a summary before the lecture, before the actual vignette that I'm going to present in a sec. I'm actually going to go through the LFTs again, which is what we covered at the end of the last lecture. And so this is because if you didn't see that lecture, if you weren't here, this will be important for you to understand what we're going to talk about in this lecture. In addition, it's also just a really important concept for GI generally. And so repetition is one of the keys to mastery. So a summary of LFTs. So LFTs stand for liver function tests. These are not, however, really tests of liver synthetic function. So they're pretty much a misnomer, right? Most people would agree that they're not actually tests of liver function. And so they're also not really liver specific. So they're very much a misnomer. So bilirubin, right? So the components of most LFTs are traditionally thought to be bilirubin, AST, ALT, and alk-phos. So for bilirubin is a breakdown product of heme. So if you recall, direct bilirubin is conjugated, right? And it's conjugated with something that's water soluble so that it can be excreted. The breakdown of bilirubin ends up coloring both your poop and your pee, right? So the stercobilin makes your poop brown and the urobilin makes your urine yellow. Bilirubin is elevated in hemolysis, right? So in hemolysis, your indirect bilirubin would be really high because you are producing a lot of bilirubin and haven't had a lot of time to conjugate it yet. So the indirect or unconjugated bilirubin would be very high. It's also elevated somewhat in hepatocyte damage, where it's both direct and indirect, and in cholestasis, where it's mainly direct. So AST and ALT are enzymes that are found within hepatocytes. And so if they're elevated, it indicates that the hepatocytes that contained the AST and ALT were damaged. So normally you shouldn't see very much in your serum. If the hepatocyte bubble or balloon is popped, in this case, AST and ALT. Alkaline phosphatase is an enzyme that's found, then the contents of that balloon are going to spill into the serum, among other places in the bile duct facing hepatocytes and the biliary canaliculi facing hepatocytes. So it's in the hepatocytes. What's interesting is that it's elevated in biliary stasis, and it's thought to be from the synthesis. They've actually shown that it's from synthesis and not from hepatocyte damage. That's important because you would think that if it was just from damage, if it was just a mechanism that was not from synthesis, right, the AST and ALT, that it would rise in proportion to the AST and ALT. But that's not what so in biliary stasis, you increase the synthesis, and so the alk-phos increases a lot. It's also important to remember that it's found in bone, where its function is best understood. It's thought to increase bone mineralization. It's also found in liver, where the function isn't really known, and in the placenta, where again, the function isn't really known, among other places. So these are probably the ones that are most common. We talked last time about how in any time that you're making bone, your alk-phos will be up, right? So Paget's disease, young children who are going through growth spurts, bone fractures, things like that, your alk-phos will be elevated, which makes sense because it's involved in bone mineralization. So in acute liver failure, again, so LFTs are not actual tests of liver synthetic function. So the tests of liver synthetic function are PTT and albumin. So PTT is going to be elevated in acute liver failure, because if I can't make any coagulation factors, the ones that have the shortest half-life, in this case factor 7, which is a half-life of 3 to 6 hours, will fall very quickly. So within a day, you're going to have, if you just took out your liver, you would have basically no factor 7 within about a day, right? 5 half-lives. However, your albumin, which has a half-life of about 18 to 20 days, would be normal, because it has a much longer half-life. So acute liver failure, PTT is up, albumin's normal. In chronic liver failure, your PTT is up, but your albumin would be low, because again, now you've had enough time that has passed that your albumin has now decreased. Cool. So I just wanted to do this summary of the previous lecture because it is very relevant to all of GI, but especially what we're going to talk about.
today.
Hey, Alec, quick question. Last week we talked about it being the PT, not the PTT.
Oh,
Is
yeah,
it the
yeah, yeah.
PT? Factor 7 for the PT.
Yeah, good call. Thank you. Sorry. Yes, I did this late at night. So yes, thank you. Other questions? So we are going to go to the vignette. So I'm going to read this slowly. So a 28-year-old woman comes to the physician with 4 weeks of worsening fatigue and dyspnea. She is otherwise healthy. Her temperature is 37 Celsius, pulse is 98, blood pressure is 115/75, and respirations are 18. On exam, she has pallor, mild jaundice, and splenomegaly. Significant labs are shown. Total bilirubin, 6, direct bilirubin, 1, leukocyte count, 8,000, hemoglobin, 6.5, platelets, 210,000, and direct Coombs test is positive. What is the pathophysiologic chronology? Specifically explain the proportion of bilirubin that is direct versus indirect, her hemoglobin and splenomegaly, her pulse and her symptoms, and the significance of her direct Coombs being positive. So I'm going to copy and paste this into the Google Doc, and I'll have you write your pathophysiologic chronologies. So I'm going to go through my pathophysiologic chronology. So the summary would basically just be she has autoimmune hemolytic anemia. So she develops anemia, and that's why her direct Coombs is positive. And so because her blood is carrying less oxygen, because she's anemic, she has to now increase her cardiac output to compensate for the lower oxygen content of the blood. So you can see the detailed pathophysiologic chronology, which actually I'll put these into the Google Doc so you can see them. But this is, you can see the more detailed one. So the detailed one is that born healthy, there's not really clear why it happens, but she develops antibodies against some sort of protein antigen on her own red blood cells. This leads to T cell dependent B cell activation. So again, protein antigen. So protein is presented to T cells. That leads to maturity, affinity maturation, and isotype switching, which is why she develops IgG, so the warm agglutinins. So this is known as autoimmune hemolytic anemia. And so immunoglobulin coated red blood cells are eventually cleared by the spleen, which is why she has splenomegaly. And so because the anemia, as we talked about, right, her oxygen carrying capacity is lower. So now she's going to have to increase her heart rate and to increase her cardiac output, and therefore increase the oxygen delivery to the tissues. Her red blood cells are already coated by, I should say, antibodies. And so that is why she's direct Coombs positive. So we'll talk about all of these things, but that is what we are going to discuss. So the summary of key concepts is, so the first thing we're going to talk about is T cell dependent B cell activation. So this requires a protein antigen. So you'll recall that MHC, which is what activates T cells, only presents protein antigens. It doesn't present carbohydrates, doesn't present fat, usually. So this leads to, when you have T cell dependent B cell activation, this leads to isotype switching, right, which is what allows you to switch from IgM to the different isotypes. It also allows for affinity maturation, right, so making higher affinity antibodies, and memory B cells. So B cells that persist in circulation that can be activated against that antigen later. We'll talk about autoimmune hemolytic anemia, which again is usually IgG, so the warm agglutinins. And so the general thing that you want to remember is that all antibodies bind better in the cold. Almost everything binds better in the cold, right? The reason why we call them warm agglutinins isn't because they bind better at warm temperatures. It's just that they are such high affinity antibodies that they can still bind at higher temperatures. So they would bind better in the cold temperatures, but because they bind so well, because again, they've undergone T cell dependent B cell activation, so you have the affinity maturation to make higher affinity antibodies, they can still bind at higher temperatures. We'll also talk about the Coombs test. So you have direct Coombs, which is where you take the patient's red blood cells and you look to see at whether they've already been coated with antibodies. So examples of this would be in a hemolytic transfusion reaction like this, right? The direct Coombs would be positive. Technically, this isn't a hemolytic transfusion reaction, but this would be similar, right? So in a hemolytic transfusion reactions, you give someone red blood cells and then they have some sort of reaction against those red blood cells, right? So that would be an HTR, hemolytic transfusion reaction. So the direct Coombs would be positive because the RBCs would be coated with antibodies that you would take out of the patient. An indirect Coombs takes the patient's antibodies it takes their serum to see whether the patient is producing antibodies against known antigens. So like Kidd, Keller, Duffy. So examples of this would be before receiving a blood transfusion, patients receive what's called a type-in screen. So the screen is basically an indirect Coombs test to see whether the patient has antibodies against minor antigens that you have to look out for. So all of these things will make more sense, but this is the summary of key concepts that you can come back to because this is the roadmap. So let's start with Gianna. So Gianna, what is the B cell receptor and how does it affect the function of a B cell? What does it become later in the B cell once it's activated?
So it's an immunoglobulin, also known as an antibody. And so it becomes in a mature B cell, it will become like the
an antibody because it will be released from the B cell and participate in what's it called? Like the type of immunity, adaptive immunity. Sorry.
Yeah, exactly. So basically, the B cell receptor is what will become the antibody later. Exactly. Yeah. Perfect. So Joni, is it Joni or?
Yeah.
Perfect. So Joni. So as a bit of background, right? So you can activate B cells either with the help of T cells. So we call that T cell dependent B cell activation, or without them, which we call T cell independent B cell activation. So T cell dependent versus T cell independent B cell activation. So what are the advantages of using T cells? Most people don't know this. So there's 3 advantages. It allows for affinity maturation, which is sometimes called somatic hypermutation, isotype switching, which is switching from IgM to IgG or IgA or other isotypes, and then memory B cell formation. So Joni, do you happen to remember what MHC stands for?
Yeah, major histocompatibility complex.
Perfect. Great. And so Satya, so what's the purpose of MHC?
MHC is part of the HLA and is a marker for cells in the body specific to individuals.
True, that's how we use it, but how does the body use it?
Oh, MHC typically presents antigen that is within, a component of the antigen that is within a phagocyte and just displays it out to the T cell.
Yeah, exactly. So MHC2 would be something that a phagocyte takes up. MHC1 would just be whatever protein is in the cell that samples it.
Yes.
But yeah, perfect. Great. You can tell that you're interested in heme or did at least heme work. Yeah, that's how they use them. Yeah. But the basic idea is that MHCs are there to present antigens to T cells. That's essentially right. That's like the USMLE view, right? So MHC1 presents it to CD8 cells and MHC2 presents it to CD4 positive T cells. So Paula, what kind of antigens, like what molecule type does MHC present?
Cytotoxic T cell and helper T cell.
So is it carbohydrate, is it protein, or is it fat, or some combination?
Protein.
Perfect. Yeah, it's a protein antigen. Good. Exactly. Perfect. But Mary, what kind of molecules, so protein, carbohydrates, or fat, can activate B cells? Right. So T cells are activated by protein, but what kind of molecules can activate B cells? All right, we'll go to Sue. Sue, what do you think?
So cells can be activated by all 3.
Exactly. So they can recognize proteins, carbohydrates, and fat. And so let's think about, so Deb, so what kind of molecules, so protein, carbohydrates, or fat, can activate T cells, and why would this make sense?
Protein can activate T cells.
Yeah, and why?
Is it to do with the memory B cell activation?
So MHC, right, activates T cells. So what kind of molecule can MHC present? Protein, carbohydrates, or fat?
Protein.
Protein. So if MHC can only present protein, and MHC is what you need to activate T cells, then it would make sense that protein is really what you need to activate T cells. This is an important takeaway, right? Protein is the major molecule that will activate T cells. That is something you need to understand. So what are bacterial capsules made out of?
They are made out of polysaccharides.
Perfect. Yeah. Almost all of them. The exception is Bacillus anthracis. So anthrax has a capsule made out of protein, basically, right? Glutamate, the amino acid. But yeah, basically everything is carbohydrate, right? So strep pneumo, the capsule is made out of sugar, right? Haemophilus influenza type B, all the typable influenzas, they're typable based on their capsule. So they're all also made out of carbohydrates. Great. So Vi, so if I wanted a vaccine to promote IgG antibodies against a carbohydrate antigen, could I use only the carbohydrate antigen itself in the vaccine? Why or why not?
Hey, if I remember correctly, I think this has to do with the spleen. The spleen and working. In one kind, you have to have a protein conjugated to your polysaccharide, and I think that was in kids. Here, and if their immune system is mature, then I think the polysaccharide alone is enough.
Close. So that's actually, so good points. Those are true. Those are true. So the short answer is no. And so the reason is because unlike B cells, T cells cannot be activated against a carbohydrate antigen, right? So if I wanted to make a vaccine against, say, so there's an unconjugated and a conjugated version of the strep pneumo vaccine. If I did the unconjugated version, and then in other words, it was carbohydrate only, I couldn't activate T cells. And again, remember, what are the things that what does T cell dependent B cell activation lead to? What are the 3 things that it leads to?
Yeah, the isotype switching, the affinity, maturation, memory.
So in other words, if I don't activate T cells, I can't
do affinity maturation, but in this case, the most important thing is I can't do isotype switching. So if I can't do isotype switching without T cells, then can I make IgG antibodies? So this is a sneaky way of trying to combine different concepts in a situation that's highly clinically relevant. Cool. So the vaccine, right? Many of the vaccines that are against the coronavirus, they're basically targeting the spike protein, right? The thing that, it's called coronavirus because it looks like a crown because of all the spikes. So that's the thing that they've chosen. Many of the vaccines have chosen as their target. So it's a protein. So do you think you could develop IgG antibodies against it? Yes or no?
Yes, T cell dependent B cell activation because T cells can respond to protein with.
Boom. Exactly. Yeah. Perfect. Yeah. So that'd be my guess. I don't know the answer to that question, but that would be my guess, actually. So this is, again, vaccines are obviously a lot in the news right now, but very important to understand. So conjugate vaccine. So Grace, what is the conjugated vaccine and what's the purpose? Why would you do this in the first place?
Is it to keep it stable? Is that why
Maybe.
you would conjugate the vaccine?
It's a good med student answer. It's like vague enough that it's probably right at least some of the time, but that's not usually the reason why they do it. So it's a protein, right? So we are circling around this idea that proteins activate T cells, and T cells, if they activate B cells, give you a lot of advantages, specifically isotype switching, memory B cells, and affinity maturation. So let's say that I have a carbohydrate antigen, and now I conjugate a protein. So it's a sugar plus a protein instead of it being just a sugar. Why would I do that?
I guess to activate the immune system, is that?
Yeah, perfect. What part of the immune system specifically? T cells or B cells are you trying to activate with the protein antigen?
Are we trying to activate T cells?
Yes, exactly. So with the protein antigen, now I can present it on MHC, like Vi said, right? She presents protein. So if I conjugate a protein onto the sugar, I can now present that protein on the MHC, which again, only presents proteins. So if I present it on an MHC, what can I now activate? T cells or B cells?
MHC. So now we can activate.
You can activate T cells.
T cells to then activate B cells.
And if I use T cells, now if I have T cell dependent B cell activation. So if I use T cells to activate B cells, what's the advantage of that?
No T cell dependent B cell activation.
So now you have T cell dependent B cell activation, right? If I have T cell dependent B cell activation, what do I have? What advantages does that confer?
Isotype switching.
Isotype switching, memory B cells, and affinity maturation. Vaccine, yeah. So the general idea is that you add the protein on in order to be able to activate T cells. I know this is hard. It's probably been like years since you've thought about this. I know you're studying precisely. This is more a test of myself to see if I can explain it. So hopefully I can do a better job moving forward. But the general idea is that you conjugate on protein. The protein activates T cells. If I can use T cells to activate B cells, then I have the advantages of these three things: isotype switching, memory B cells, and affinity maturation. I apologize. I don't think I did a very good job of explaining it. What questions do you have?
Oh, no, you're good. It's just been a while since I've gone over NH1, 2, and T cells, B cell activation.
Yeah, it's the blindsiding setting, I think, a lot of you guys. So yeah. So note that this is a very common strategy for making vaccines against non-protein antigens. So like Hib, right? The Hemolysis type B vaccine is a conjugate vaccine. The pneumococcal PCV13, that's the conjugate one. There is an unconjugated version, right? There is of the pneumococcal vaccine, but the PCV13 is. And then the Neisseria meningitidis vaccine also is conjugated. But again, it's all to do this. It's to make better antibodies, to make IgG antibodies. So let's go to Leah next. So Leah, conjugate versus unconjugated polysaccharide vaccine. So what isotype would you expect in a conjugate versus one that's not a conjugate polysaccharide vaccine, and why?
So if you are conjugating it, like you were just saying, and we have the protein there, so you can make the IgG. If you're not conjugated, if it's polysaccharide, then you would only create the IgM because you're using the B cells for that. So you don't get the isotype switching.
Perfect. Yeah, exactly. So conjugate can make any isotypes. So usually it's IgG in this case, because you're injecting it into what eventually goes into their serum. And so an unconjugated polysaccharide vaccine, you can only produce IgM. And that's because you don't have the protein conjugate, so you can't activate T cells. If you can't activate T cells, you have no isotype switching, and you'll only make IgM. So Vi is asking, will we go over isotype switching the order it happens? Not particularly, other than to say, the first one that you make is IgM. And then if you do isotype switching, it depends on the cytokine sort of environment, but you can make any of the others, I don't think that you have to go through a particular order. Like, I don't think it goes from like IgM to IgG to IgA. I think you just go straight from IgM to IgA. Does that answer your question, Bai?
Yeah.
Yeah, so you always start with IgM, right? Which is why that's the one that tells you if it's an acute infection or not. And then after that, it can become. So we just talked about isotype switching, which depends on T cells. And so again, isotype switching is where you have a protein antigen that's presented in MHC. That protein MHC complex can activate T cells. And with the T cells, you can activate B cells. And if you have T cell dependent B cell activation, you can have things like isotype switching, where you go from IgM to other types of antibodies. And you can also have what's called affinity maturation. So let's go to, I think we're on Zach now. So Zach, so what does the B cell receptor eventually turn into? We talked about this.
Eventually turns into an antibody.
Yeah. So eventually it's technically the FEB portion of the B cell.
Oh, okay, yeah.
Right? But yeah, it's the antibody, right? So Zach, when a B cell first makes an antibody, what is the relative affinity of the antibody for its target? And what's the consequence of this? In other words, how well does it bind?
I would say not so well.
Not so well. It's like okay.
Yeah.
But it's not great.
That's not optimal.
Yeah. Remember, when basically the way that your immune system works is that you have to come up with B cell and T cell receptors before being exposed to any pathogen that could recognize any protein antigen in the case of T cells, or any antigen period in the case of B cells. You have to create a whole complement of these cells. So they're not going to be a perfect fit in the beginning. And so the relative affinity is low. And so that means that the antibody won't bind well to the antigen. And so Sujith, so how do B cells evolve to produce higher affinity antibodies? What do we call that?
I don't know.
Affinity maturation. So this is like a fancy way of saying that your affinity is maturing, right? It's getting better. Rosa, do you happen to know what exactly is affinity maturation?
Is it something with a BDJ recombination?
Close. BDJ recombination is really to make the B cell receptor in the first receptor. So affinity maturation. So most people don't know this. So let me explain. The basic idea is that you have an activated B cell that multiplies. Right? So let's say that this is B cell number 1. Right? It's B cell receptor. This is the antigen that it's trying to bind. Right? This is the pocket. It's going to bind, but not great. You can see this will fit, but it's not a great fit. In other words, the affinity is. So what happens is that I take this one B cell and I make many copies of it, each of which is going to have a slightly different B cell receptor. And so what will happen is that all of these B cells are now going to compete to try to bind to that antigen. And the ones that bind better are going to survive. And the ones that don't, let's walk through exactly what this would look like. So affinity maturation, where only the best binders survive. So again, we've got our B cell, number 1. This is the B cell that does not bind very well to the antigen, but it binds, as Zach said, it's a low affinity interaction. So the first step of affinity maturation is that you have many B cells. So now I'm just making 3 B cells, but it's probably many more than that. But let's just say that there's 3 in our example. So the B cell copies. There's many copies of the B cell. It all has a similar B cell receptor, but they're all a little different. So then now they're going to compete. They're going to see, hey, can I bind better? Can I bind better? Can I bind better? They're all going to try and bind to that antigen. So B cell 2 is going to bind. B cell 2 looks like it's going to bind the best. And then B cell 3 is way too narrow. No way that B cell 3 is going to bind. So then Jaya, what's going to happen? So the ones that don't bind well, what's going to happen to the ones that don't bind well? So B cell 1 didn't bind that well. So what's going to happen to B cell 1?
If I recall correctly, it would undergo deletion.
Yeah, exactly. Yeah, so it's not going to bind well. It's going to get kicked off from the interaction, and it's going to die. It will apoptose. B cell 3, again, this B cell receptor, right, this variant of the original, is not going to bind that well. So it's also going to get kicked off, and it's going to die. So now we're left with the one B cell that binds the best. It's not a perfect binding, but it's certainly better than it was before. And so now what you do, so it's going to survive at least this round of affinity maturation, and then the process repeats. So now this will multiply itself. You'll have slight variations of its B cell receptor on each copy of the B cell that comes from this. And they will all compete and one of them will survive. And then the other ones are going to die. And then the surviving B cell or B cells are going to multiply until you have a B cell receptor that now binds really well to that antigen. Because what you're trying to do is you're trying to have that future antibody bind really well to the antigen. So the end result, again, if you're studying for SEP2 and you're like, just get to the point, right? The end result is that the final antibodies after T cell dependent B cell activation are going to bind much better, right? So in other words, if I have a protein conjugate, or if I have a protein antigen, because the protein can be presented on MHC, and because that MHC protein complex can activate T cells, I can now have affinity maturation and isotype switching and memory B cells. But because of the affinity maturation, now the ultimate antibody is going to bind. This is going to be very important because this will explain the phenomenon of warm agglutinins and why they're IgG. So this matters for step 2. So bear with me. So Gianna, so affinity maturation. So explain the process to describe why it's going to benefit a B cell. So why is that good for the B cell?
So the process I think that we just went over was affinity maturation, whereby like the B cells with the B cell receptors that have the highest affinity for the antigen are able to survive and undergo clonal expansion to duplicate itself. And so I guess it benefits a B cell because it makes it like more specialized to one particular antigen.
Perfect. Yeah. So the B cell receptor is going to bind with a much greater affinity, which means the future antibody is going to bind with a much better affinity. Yeah. And so Joni, so T cell dependent versus T cell independent B cell activation. So which produces higher affinity antibodies and why?
Would it be T cell dependent?
Yes, absolutely. So why would you get higher affinity antibodies with T cell dependent?
It's like how we were explaining. You need the T cell to be able to, that the process of generating antibodies. I'm sorry, I don't know how to really word this.
I know, it's hard. Yeah, it's hard. Yeah. Which is why I'm like, you'll see that a lot of these questions are variations on each other because I'm trying to build on it. Because I know that I'm taking slower steps along this because it's really tough. So I'm trying to go slow on this one. So because you have T cell dependent B cell activation, you can have affinity maturation, right? The whole point of affinity maturation is to make this B cell receptor fit better with the antigen.
Exactly.
And so ultimately, the ultimate product is that you'll have higher affinity antibodies for the antigen. So the punchline again is going to be that for something like warm agglutinins, which are IgG, they've undergone T cell dependent B cell activation, which is why, so they are higher affinity antibodies. So even when you warm them up, they are still able to bind to the antibody. That's going to be one of the punchlines of it. I know it's tough. Yeah. So bear with me. So Satya, so what's the first antibody isotype that's made in response to an infection?
IgM.
Always IgM. Good. So what's unique about the structure of IgM?
It's a pentamer.
Yeah, mer I think means wall. So penta is 5. So great.
Yeah.
And so Melissa, if you're there, you can unmute yourself. If not, we'll go to Paula. So Melissa or Paula. So IgM. So use its unique structure to explain when it is made relative to other antibody types. So awkward question. So basically the idea is that because IgM is produced before the isotype switching, each of its 5 heads has weak affinity for its target, right? Because it makes sense, because by having 5 heads, I don't know, I guess it gives it a better chance to bind, more chances or like places to bind is sort of the way that I would think about it. This is sort of a hand-wavy explanation, but this is the way that I would think about it. So let's go to Sue. So what isotype is best for mucosal protection?
Right. So that's going to be IgA.
Perfect. And so T cell dependent versus T cell independent B cell activation. So which would be better for an infection against bacterial pneumonia, Sue?
Oh, so I would guess if it's IgA and you would need isotype switching, that would be T cell dependent.
Yeah, exactly. So ideally you would have isotype switching, right? So you could make IgA antibodies. So you could protect the mucosal surfaces, and you could have better protection against encapsulated bacteria. This is one of the things that like you'll see with the different kinds of polio vaccines. So Sabin, I think, is the live attenuated, and Salk is not. It's the inactivated one. So Sabin is actually given orally. I think you drink it. And so you actually make IgA antibodies for the live attenuated version because you're giving it basically against a mucosal surface. So it makes sense that you would make IgA antibodies. Versus Salk, still a protein antigen, but you will not get IgA antibodies. I think it's only IgG. So Deb, so what is agglutinin? What is it? What does that mean? So it's usually an antibody, but it can be an antibody, a lectin, or other substance that causes agglutination. I know, weird. So basically it's, again, usually an antibody that binds to an antigen and causes clumping. That's it. Because again, what we're trying to explain is what we mean by warm and cold agglutinins. Deb, so what do you think hemagglutinin means? So use its name, heme agglutinin. So use its name to explain what it causes in vitro.
It's a substance that causes agglutination of the blood.
Exactly. Yeah. So hemagglutinin is something that causes agglutination in the blood. It's also the name of a protein in influenza, right? So the H1N1, hemagglutinin is what the H stands for. But in general, it's a substance that causes clumping in blood cells. So heme.
So in the case of influenza, it's the thing that binds to the sialic acid residues, which I didn't know. The reason why is because there's also sialic acid residues on RBCs, right? So it binds to the sialic acid. It's what allows it to bind to the respiratory epithelium, but it also will bind to the surface of RBCs, and that is ultimately what allows it to be internalized into the respiratory epithelial cells. So I was trying to figure out like what the significance is of the fact that so it binds to RBCs. So what does that mean? Is that like beneficial to the organism? But it's not clear to me that it really benefits influenza at all to be able to bind to red blood cells. It is used, I found out that it is used in the clinical hemagglutination assays. So basically you can figure out how much influenza or pathogen there is based on the amount of agglutination there is. But yeah, it's not the main thing that you need to know for tests and for life is that this is the thing that allows it to bind to sialic acid residues on respiratory epithelium. The H allows it to bind to the sialic acid on the respiratory epithelium, and the N, the neuraminidase, allows you to cleave the sialic acid so that it can then leave, right? Because if you didn't cleave it, then any influenza virus that was to leave that respiratory epithelial cell is just going to bind right back onto the sialic acid because you've got hemagglutinin there that'll just bind to it. So you need something that will allow it to bind it first to get in, and then the neuraminidase is there to cleave it so the viruses can leave. Perfect. So antibodies. So in general, do antibodies bind better at warm or cold temperatures, and why?
I am not sure, but I would guess warm.
It's actually cold.
I don't know why.
Yeah, it's actually cold. So almost everything, if you go back to like chemistry, right? Virtually everything, including antibodies, bind better at colder temperatures. There's probably exceptions to this, but like in general, right? The warmer something is, the more kinetic energy there is, meaning the more they're moving around, the more kinetic movement there is in the molecules. So the colder something is, the less they're going to be moving around, which means the less that the molecules are going to be forcing themselves apart. So this is why, right? So their molecules are going to be closer to each other, so they're going to bind better. And so so when we say a warm agglutinin or a cold agglutinin, what is that actually referring to?
Antibodies that bind in a cold temperature versus warm, and in a warm temperature binding means even stronger affinity.
Perfect. Exactly. Yeah. So warm agglutinins really they're just an antibody that can cause agglutination at warm and cold temperatures. Because again, this is what always confused me at your stage, is I thought warm agglutinins, oh man, just not doing well with the spell check here. So warm agglutinins, I always thought that it was I thought it was like what we said, right? I thought that warm agglutinins would bind better in warm and less in cold. That is not true. Everything binds better in the cold. It's just that, as Vi said, warm agglutinins bind better, so much better than cold agglutinins, that even in warm temperatures, they can still bind. Whereas cold agglutinins are antibodies that can cause agglutination only at cold temperatures, but when you warm it up, they can't.
Alec, I have a question about that. So when it's cold, is that what you were showing, the IgM structure? You would want less kinetic energy because the IgM is like the pentamer, and so then they could bind easier in the cold? Do you understand that?
It's more just that, so I think it's unrelated to the fact that it's a pentamer, or at least you don't have to invoke the pentameric structure. The point is more just that in colder temperatures, that there is less kinetic energy, right? Because again, temperature is basically a measure of average kinetic energy. Go back to it. So yeah, so the colder temperatures, they're just the molecules, the antibody and the antigen are just moving around less at colder temperatures. So you're able to have binding more effectively. Because the more that they move around, the more you're going to break the bond between the two. So Grace, so which one would bind better than the other, and why?
We talked about warm versus cold. Would the warm agglutinins bind better because they have a greater affinity?
Yeah, and why would they have a greater affinity? What would they have undergone in order to have that greater affinity?
Do you mean by the selection process or just by sheer kinetics?
I guess both. So warm agglutinins have a higher affinity because they've undergone affinity maturation, that selection process where you have all the B cells multiply and then only the best binders. So Leah, so warm versus cold agglutinin. So use the meaning behind each name to explain what antibody isotype you would expect them to be.
So cold, I would think, is IgM. And because we were just saying it has not undergone the affinity maturation, so you would not have anything except for the IgM, and then the warm would have IgG.
Perfect. Yeah, exactly. Because in this case, the fact that it's isotype switching is incidental, but it's an indication that you have had T cell dependent B cell activation. Good. Yeah. So off the warm agglutinins, right? So warm agglutinins again cause agglutination,
at both warm temperatures and cold temperatures. That's again, this is usually because not only have they undergone affinity maturation, but they've also done isotype switching. But the big thing is the affinity maturation. So often cold agglutinins, as you said, are IgM for the reasons that you explained. Perfect. So we're going to talk about the Coombs test next. So Suja, so if you take RBCs, right? So I take someone's RBCs and they already have anti-RBC antibodies on them. And then I add the Coombs reagent, right? So this anti-human antibodies, right? So that would bind to antibodies. What will happen if I add antibody-coated red blood cells and anti-human antibodies? What will happen to those?
They'll agglutinate or clump.
Yeah, they clump. So this is what's known as the direct Coombs test, right? So you're taking RBCs from the patient and you add the Coombs reagent. And so Rosa, so for the direct Coombs test, if you see agglutination versus if you do not see agglutination, what does this mean? What does that indicate?
Whether there is presence of antibodies against proteins on the red blood cells or not, if there is agglutination.
Good. But let's be very clear, right? Because it's really easy and it took me years to understand the difference. So you'll have to forgive me for making sure that we cover this in more depth. So where are the antibodies? Are they in the patient's serum or are the antibodies already bound to the red blood cells?
They're already bound to the red blood cells.
Perfect. Great. So in other words, if you see agglutination, that means that the patient's RBCs already had antibodies on them. And all you had to do was add this little Coombs reagent, the anti-human antibodies, and that caused them to clump together. So the antibodies were already on the red blood cells. That's the critical thing. So if you don't get agglutination, the RBCs did not have antibodies already on them.
So why does adding the Coombs reagent cause red blood cells with the antibodies on them to clump?
You can understand it by like this. You can see like the cross-linking, right? So the idea, again, I don't know how accurate this is molecularly, but the idea is that you've got like one FEB part can bind to one antibody and the other part can bind to another antibody.
Creates like little bonds between the red blood cells.
Exactly. You can see you're essentially creating like a bridge between these two.
Got it.
And so
Thank
if you
you.
have enough, right, you can create this clump of red blood cells. Great question. Yeah. You'd think like, why? Yeah, it's because these antibodies bind to human antibody. Great. We'll go to Zach. So Zach, what are the steps in the indirect Coombs test?
This one always trips me up.
I
So
know,
it's
me too.
backwards. So I think you have, I'm just reading off of the picture as well. So you have this test tube filled with free antibodies to RBCs, I would imagine. And then you,
what are you taking from the patient?
Serum.
And why are you taking the serum?
You want to see if they have antibodies to RBCs.
Great. So this test tube is what you take from the patient, right?
Yeah.
Serum to see if they have antibodies in them already. Not antibodies coating red blood cells already, just the antibodies that could potentially coat red blood cells. And then you add what?
Then you add RBCs into that test tube.
Exactly. And then the next step is what?
So then you add the Coombs reagent, right?
Exactly. And then you see do they clump or not. So in other words, the first step is that you take the serum. So again, this is a critical difference, right? So in the direct Coombs test, you're taking literally their red blood cells versus in the indirect Coombs test, you're taking their serum.
Yeah.
And then the second step in the indirect Coombs is that you're adding red blood cells with known antigens on them. Usually you'll do multiple sets of these, but yeah. So you'll add red blood cells and then you'll add the Coombs reagent and then you'll look to see whether.
I have a question. So hypothetically they have the antibodies in their serum already. So if they have the antibodies, why are the antibodies free in the serum and why aren't they already on patients' RBCs?
Great question. Yeah. So you do this usually for this is like a type in screen. So it's kind of about, so obviously you shouldn't have antibodies against your own red blood cells. That would not make sense. You would die.
Yeah.
However, let's say that you need blood. They have got this blood. It's ABO type match. So you're A positive and this blood is A positive. Let's just say.
All right.
If I give you that blood, maybe you have antibodies that aren't against the A or the B, right? Maybe you are ABO compatible. However, maybe you have antibodies against one of what they're called minor antigens, like KID, Kel, Duffy. Those are the big ones.
All right, thanks. I got it.
Yeah. So I want to know if I give you red blood cells, are you going to reject those red blood cells?
All right.
So great question. I didn't know this. I did a heme rotation at MGH. It was I was like, oh, makes so much more sense now. Yeah. So if a patient has anti-RBC antibodies and the RBCs have the antigen, then you'll see agglutination. So in other words, an indirect Coombs is positive if the patient has, they're called atypical antibodies. So atypical antibodies means antibodies against something that's not on their own red blood
blood cells. So let's go back to Gianna. So Gianna, so direct versus indirect Coombs. So use what you take from the patient to explain what exactly you are looking for.
So direct, you are taking red blood cells that already have antibodies on them to see if they agglutinated.
Sorry, you're taking red blood cells to see if they have antibodies on them.
Oh, because if they clump, then you know that they have antibodies on them. And if they don't, then you know they don't have antibodies on them.
Perfect, exactly. So that's the direct Coombs. So what about the indirect Coombs? What are you looking for?
So you're taking their serum, so you're trying to see if you gave them a blood transfusion, if they would reject it.
So you're seeing, do they have antibodies against red blood cells, against known antigens on red blood cells? Not their own red blood cells, but against red blood cells in general. And again, like you said, the most common way in which you would see an indirect Coombs is a type-in screen. So if I'm thinking about giving you a transfusion, I will run a type-in screen beforehand, because I would hate to give you a transfusion and then you have a hemolytic transfusion reaction, get like trolley and die. That'd be bad. So Joni, so direct versus indirect Coombs test. So when exactly would you perform? So we talked about the indirect. So when would you run an indirect?
Usually, don't you give these like for hemolytic anemias, like check for like for pregnant women?
Great. So direct, which would you do for a hemolytic? If you were working up a suspected hemolytic anemia, which would you do? A direct or an indirect test?
Indirect?
I guess you probably could, but the more smoking gun one would be the direct. So let me think better. So I didn't, this is a hard one because there's no reason that I don't even think I would have known this at your stage. So if you suspect immune-mediated hemolysis, you would do it. So in other words, if you suspect that someone is lysing red blood cells, either their own or someone else's already, in other words, you are, right? Because in other words, you have to think, when would I want to find whether antibodies are already bound to red blood cells?
Oh, right.
The time that I would want to figure that out is if I suspected hemolysis.
Correct.
If I suspected that they were already hemolyzing blood, either their own or transfused blood.
That
That's generally when you do a direct Coombs test. Indirect Coombs test is to assess for antibodies against red blood cells, usually before transfusion or in pregnancy.
Right.
So these would be the most common, right? So a type-in screen and like the anti-RH antibody would be the most common indirect Coombs tests.
Right.
Versus direct. Because again, there you're looking, do they have the antibodies? Hope that makes sense. So this is probably the most important thing for you guys to remember about the Coombs test is when would you use them? And this is also the thing that didn't make sense to me for the many years. So I know that I didn't explain that perfectly. Probably not even. So what questions do you guys have?
I actually have a question about agglutinin for Dr. So I think in mycoplasma pneumonia, cold agglutinin is the test for that. I'm trying to figure out why would mycoplasma pneumonia cause cold agglutinin?
Yeah, that's a good question. I don't know is the short answer. I would imagine that it is because I think it has to do with their membrane. I would imagine that it's a similar enough membrane to red blood cells. So first of all, why is it IgM? Because it's not a protein antigen, would be my guess. So if it's not a protein antigen, you'll have IgM, and again, you won't have isotype switching. So there's something on the mycoplasma that is, so you're making antibodies against mycoplasma, right? That's the idea. And for whatever reason, it is cross-reacting. There's something that's similar enough on someone's red blood cells that it's cross-reacting. So it's probably not a protein, because presumably then it wouldn't be a cold agglutinin. So it's probably something else. I think that it's hypothesized that is like something in the membrane itself, which should be fat. I could be wrong. Does that make sense?
Dr. Palmerton, on the same question, is it safe to say that if it's a cold agglutinin, just by raising its temperature or something, you can inactivate its ability to agglutinate just from the warm, cold hypothesis?
Yeah, I agree. Yeah. So in other words, so I think what you're asking is like, when do cold agglutinin present?
Yeah, because mycoplasma pneumonia, it doesn't have the clinical picture as bad as the radiograph. So.
Oh, I think that's unrelated though.
Oh.
I think you're correct. That is true. Walking pneumonia. So atypical pneumonia. Yes. The walking pneumonia. So it gets that name because the X-ray looks so bad. You're like, oh my gosh, you must be so thick. And then what?
I'm just trying to think if it is literally temperature and if it can translate clinically or not.
I think so.
The cold agglutinin.
I don't.
Okay.
It'd be cool. That'd be cool. If you can make that connection, that'd be awesome. I love connections like that, but I don't see it as of yet.
So maybe you can just give a fever and the patient can just get better.
So we'll do a quick lab interpretation. What I'm going to ask is explain the relationship between the direct Coombs, the hemoglobin, and the bilirubin. Because again, we're trying to make essentially a pathophysiologic chronology from just the labs. Grace?
So the direct Coombs is positive. Are we suspecting possibly that they have hemolysis, and that would be the why they have an increased indirect bilirubin?
Boom. Great. Yep. So direct Coombs tells you what? So if it's positive, what does that tell you?
If it's positive, that means that they have antibodies binding to the red blood cells.
Exactly. So that's like the smoking. That's like about as clear of evidence as you can get for hemolysis, like hemolytic anemia, or specifically like immune-mediated hemolysis. Great. So that would explain why you have an increase in your indirect bilirubin. Great. How about the hemoglobin? Can you explain that in context of the hemoglobin?
In context of the hemoglobin, we have a decreased hemoglobin. Usually we transfuse at around 7. That means that they are having their red blood cells they're having their red blood cells hemolyzed. So they have a decreased volume of hemoglobin.
Boom. That was great. That was really good. Wow. And to think, you're studying for step 2 and you can make these connections. That's good. That's great. Now, as Grace pointed out, right? So the direct Coombs is positive. That means that the RBCs are coated with antibodies. So again, in this context, it indicates that there's some sort of, doesn't necessarily mean it has to be autoimmune, but there's an immune-mediated hemolytic anemia that is leading to red blood cell destruction. That explains why there's low hemoglobin, but also, because again, bilirubin is the breakdown product of heme, which is part of hemoglobin. So that's also why there is an increase in the indirect bilirubin much higher than the direct bilirubin, because all of the hemoglobin in your red blood cells is being, all the heme in the hemoglobin in your red blood cells that are being destroyed is being converted to bilirubin. Boom, that was great. All right, so we are back to our vignette. So I'm going to have you guys revise your pathophysiologic chronologies to include as much detail as you can about all of the mechanisms. Again, go wild, because you won't necessarily do this in the real exam, but the more that you can connect these things and use the knowledge, the better it will be solidified in your mind so that you can use it next time. So let's go to the Google Doc, revise your pathophysiologic chronologies, and we will talk about it. Great, let's talk about that. Yeah. So let me walk through, because Vi, I think, had the same question, which is a good one. You're asking why she tachycardic.
While also the blood pressure is kind of low.
The blood pressure is not necessarily that low. It's more the pulse is high. Let me read through and tell you how I would think about this first, and then we'll talk about so let me analyze the question. So I'm going to do like I did last time. So I'm going to analyze the question as if I was reading it to try to give you a sense of what you can expect or how to think about it. And then we'll talk specifically about the heart rate. If I don't answer your question, please tell me.
Yes.
So a 28-year-old woman comes to the physician with 4 weeks of worsening fatigue, dyspnea. So dyspnea is a little bit more specific. You can get down to systems. So dyspnea is either a heart problem, a lung problem, or anemia. So between these two, again, like it could be a heart lung problem. So again, fatigue nonspecific, it's probably still heart lung or anemia. That's 4 weeks. In a young woman like this, unless it's something really strange for heart or lungs, it's probably anemia. But you don't necessarily know. She's otherwise healthy. I would think probably anemia. But again, try to keep somewhat of an open mind. Her temperature, I don't know why, but maybe. Her temperature is normal. Her pulse is on the higher end of normal. Her blood pressure, I would just say is normal, right? It might as well be 120/80. The bigger thing that I'm looking at is the pulse. Her respirations are a little high. Again, neither are technically high, but they're the higher end of normal, like much higher end of normal. So that would make you think, again, non-specific, but if you're thinking anemia, that would make total sense. And we'll talk about the mechanism for why that is. The short answer is because there's less oxygen in the blood, I need to pump more milliliters of blood to my tissues to deliver the same amount of oxygen. So my cardiac output has to increase, right? I'm also going to have to oxygenate that blood more, which is why I would have to respire more. So on exam, she has pallor. So again, now you're thinking definitely anemia. Mild jaundice, which now you're thinking hemolytic anemia, because otherwise you shouldn't be increasing your bilirubin. And splenomegaly. So now you're really thinking hemolytic anemia. So now all these things fit, right? Hemolytic anemia, so I would be doing a pathophysiologic chronology in my head. Hemolytic anemia leads to destruction of red blood cells, leads to low oxygen content, leads to high output, leading high cardiac outputs to try to compensate. And because she can't perfuse her tissues as well, she's getting tired and dyspneic. Her labs basically fit everything that I would expect. Indirect hyperbilirubinemia, leukocytes are normal, hemoglobin's low, fits with hemolytic anemia, platelets normal, and her direct Coombs is positive. Again, telling me that there are
antibodies coating my red blood cells. So that's basically it. That's how I would analyze this. Questions about that before I talk to you about the rationale for why she's tachycardic or her heart rate is higher than normal. So if I want to explain this well enough that you can understand this. If I don't, please tell me, because it means that I didn't do a good job of explaining it. So you may remember that the equation, I think I wrote this wrong before. It's 1.34. So oxygen content, right? The oxygen content equation is one of those things that you've probably memorized at some point, thinking like, why is this useful? You will never actually, I've never seen this actually used, like the actual number used, but the concept is very important. So this is the concept, right? So the concept is that in my blood, the amount of oxygen that I can carry is going to depend both on the oxygen that's bound to my hemoglobin. So this is the oxygen content equation, right? So 1.34 times hemoglobin concentration times the O2 sat. So you guys have probably seen this before. And so what this equation is basically telling you is that if you do the math, we can actually, let's do the math, right? You'll never do this in real life. It's useful to do the math. So OG content. It's useful to do this because it shows you like what the point of this equation is. So a normal PaO2, let's say, to make the math easy, is 100. And the normal O2 sat, we'll just say is 100%. So normally true. So hemoglobin, the low end of normal for a girl. So we'll use maybe, we'll just say 12. So if you do the math, if someone can do this for me. So 1.34 times 12 times the SAT, which is 100%, so 1, plus the PaO2, which is 100, times 0.003. Right? This is the, but let's be very clear. So when you do this, when you do the math, can you do it so that the terms are separate? So this, because this is the O2 bound to hemoglobin is this term, and then the O2 dissolved in the plasma, this term, right, is the second term. So 1.34 times 12 is what? 15-ish? Great. So 15.08, pretty large number. What is 100 times 0.00?
16, sorry, 16.08.
Okay, so what is 100? So what is 100 times 0.003? It's about 0.3. Okay, so in other words, the reason why this equation is so valuable is not because the individual terms, or it's not because if you think this is 1.54, 1.74, 1.14, it doesn't really matter. Honestly, this term doesn't really matter. And memorizing that, 0.003, like if you forget it and it's like 0.006, it really doesn't matter because the amount of oxygen bound to hemoglobin, so Gianna, Vi, let's do Vi. So Vi, so how much, relatively speaking, right, how much oxygen is bound to hemoglobin relative to how much oxygen is dissolved in the plasma?
Yeah, a lot more.
Yeah, it's like many times more. So if I was so anemic, what if my hemoglobin dropped to half? So what if my hemoglobin was 6?
Yeah, it'd have a dramatic effect on the total oxygen delivered to tissues.
Yes, exactly. Yeah, exactly. What if I drove my P(a)O2? What if I drove that to 600? What if this number increased by 6 times, right? I gave you a non-rebreather and just flooded your whole system with oxygen, but you're still anemic.
Right, because again, the hemoglobin bound oxygen, it's still orders of magnitude more.
Yes, exactly. So in other words, so in this case, this person it's roughly half, right? Their hemoglobin was 6.5, but for the sake of making the math easy, let's just say that it's 6, right? So in anemia, so in this patient, so in anemia, let's say the hemoglobin is 6. Now, the oxygen bound to hemoglobin is halved. It basically goes from 16 to 8, right? It's basically cut in half. So that's a dramatic change. That's basically half of all of it. Like, you can basically ignore this term. You might as well not even have that there. This contributes almost not at all. Almost all of it is hemoglobin. So Vi, what would happen? So now the amount of oxygen in my blood is now roughly half of what it should be, right? Now that I've been hemolyzing. So how much, if the demand for oxygen from my tissues is still...
Yeah, so cardiac output would have to double to compensate.
Perfect. Exactly. At least double, right? Because remember, as your cardiac output increases, the demand from your heart for oxygen is actually increasing as well. But it has to at least double, in other words.
So in this process, there isn't any baroreceptor involvement or decreased preload.
It's not from a decreased preload. Yeah, because remember, your blood volume isn't changed. You don't have to invoke, like, they're not necessarily hypovolemic. So if they stood up, they wouldn't necessarily be like orthostatic. You can have, in like blood loss anemia, if you were bleeding, you could both be hypovolemic and anemic. But anemia does not imply that you have to be. Does that make sense?
Yeah, thank you.
Yeah, absolutely. So does that explain then, does that answer your question then about why this person would have a heart rate that's a little bit higher than you'd expect?
Yes.
Yeah, because their oxygen content is lower. So therefore their cardiac rate has to increase because their demand for oxygen is going to be roughly the same, if not a little bit higher.
Along those lines, do you think that the increase or the doubling of cardiac output for anemic patients puts anemic patients at risk for like left ventricular hypertrophy?
Oh, that's a good question. Oh, that's a really good question. I guess if it was chronic enough, maybe,
Okay.
but that'd be pretty chronic. I've never seen that.
Just
That is theoretical, maybe, but then you also run the risk of, with chronic ischemia, of having ischemia to the heart too. I don't know. If you showed me a case report of some woman that like had to be bled to a low level and she was otherwise completely healthy and like, I would believe it, but I wouldn't necessarily go out looking for it. Other questions?
I just have one question. It's about when you mentioned the anemia and the hypolemia part. I just didn't quite catch on that one.
Oh, sure. So anemia technically just means that you have a low hemoglobin. Hypovolemia means that you have a low blood volume.
Exactly.
But those are not necessarily the same. And I'll give you a good
Okay.
example in anesthesia. So let's say you lose a bunch of blood in the surgery. I could replete all of your blood with albumin or crystalloid, right? Like normal saline or something. So the amount of fluid that is sitting in your blood vessels is a normal amount of fluid. However, you could be very anemic, right? Your hemoglobin could be 4, but your total volume might be okay. Great question.
Thank you.
Yeah, I should explain that better.
Just one question.
Yeah.
In lines of like can you include in the pathophysiologic chronology that there's a FAS mutation that causes the decreased apoptosis of the T lymphocytes, causing the T cells to produce antibodies against the protein of its own antigens?
So you're saying, so there are some autoimmune conditions that are hypothesized to be FAS, at least in some way related to FAS. Like I think Sjogren's maybe is one of them. You're saying, could that be related? Could FAS be somehow tied into the autoimmune hemolytic anemia?
Yeah.
Maybe. I don't think so though, because remember, FAS is more T cell problems. So it's where T cells are attacking things that they shouldn't. And so normally FAS tells T cells to die, FAS ligand, or it's one of the mechanisms in which T cells can die or kill other things. Maybe. I don't know. I guess though. I
Like
actually
a
don't
FAS
know. If you told me, yeah, there's like a FAS component to this, there was like an interesting study that just came out in JAMA, sure, I'd believe you. But I don't know that is true in this case.
No, if there's a mutation of the FAS?
It could be. I don't know that it is known what the etiology is. I personally do not know the etiology. I don't know that it is known though.
Sorry, I derailed it.
Other questions?
Can I just ask you one question about why the whole thing of when there is autoantibody production and then when the antibodies already bind to the RBC, what is happening with T cell signaling at this point?
I don't know that there is much happening with T cell signaling at this point.
Because in your pathophysiological chronology, you have develops antibodies against protein antigen on their own RBC, and then T cell dependent T cell activation, affinity maturation, and IgG. So I'm thinking, is that the process behind the auto antibody production, or is it, what is the link between the two?
So in other words, there's some antigen that's somehow activating T cells and B cells together.
Yeah, when there are already antibodies that are binding to the RBC, why are the T cells involved at this stage?
Oh, you're saying this should probably be...
Yeah.
You're right. That's a much more elegant way of saying it. The actual chronology of it's a little off. You're right. That's a little strange. So really, yeah, gosh, I would say unclear etiology. So immune activation against protein antigens on your own red blood cells. So that somehow you get T cell dependent B cell activation. That would lead to affinity maturation and isotype switching. And then you would get, that's how you can get IgG. Is there a clinical difference between cold agglutinins versus warm agglutinin AIHA? Vi is asking. In symptoms, yeah. So typically, autoimmune hemolytic anemia typically is more warm agglutinins, which kind of makes sense, right? Because they're going to be higher affinity antibodies. I think cold agglutinins, if they do present, typically it is actually in the cold. So it's extremities. If you get cold, it'll happen in like if you get like cold extremities. So I think that this actually does play a role in the actual presentation, right? That if you keep warm, you are less likely to get hemolysis from cold. Yeah, great question. So this is the summary of key concepts. In the interest of time, you guys can rewatch the first part of this to go over the summary of key concepts, or you can just look at this. The thing that I will emphasize, though, is the direct Coombs, right? So again, remember, in direct Coombs, basically you're looking for hemolysis, right? You're looking for evidence of hemolysis. So red blood cells that are already coated with antibodies. Whereas in indirect Coombs, you're looking for the presence of antibodies. So the classic one would be type and screen, right? Before you're going to give someone a transfusion of someone else's red blood cells, you want to see, do they have antibodies that could bind to those red blood cells? The other one would be RH,
to see for moms? Do they have Rh antibodies that could attack the baby? Well, thank you guys very much.
So the question is asking, what is the tubular osmolarity compared to the serum in each of these three places in nephrogenic diabetes insipidus? And so we all agree that the medullary collecting duct would be hypotonic compared to the serum because you don't have the ADH to reabsorb your water, which would normally be occurring in the medullary duct. Stop me if I'm wrong. Or...
exactly.
Okay, and then at the juxtaglomerular apparatus, we're also saying that it would be hypotonic because a normal person would respond in the hypotonic situation by releasing ADH or in your RAS, but she can't do that, but it would still be hypotonic. And then I was a little hung up on the proximal tubule because I know that it has isotonic reabsorption, and so I was wondering if compared to the serum, even though our serum is lower, not as concentrated as ours would be, it would be isotonic.
So who would like to answer that question? So what is the osmolarity in the proximal tubule? Who can answer that? If you don't say anything, I'm going to pick on you guys. Let's go with Mo. Mo, what do you think?
It's isoosmotic.
Iso. Okay, and why is that? Why is it isoosmotic?
Because of bulk flow, which was like everything goes through the basement membrane. It's like where the
because everything goes through the basement membrane. That's true. But what about all the reabsorption? Like Melissa was saying, but what about all the reabsorption of that solute? Well, I'm gonna pick on Maria. Maria, what do you think?
I know that fluid is supposed to be isotonic.
It's supposed to be isotonic. Yeah. Why?
Yes, because you are in the glomerulus, you're putting a lot of water and solutes inside of the tubule. However, over 75% of it will be absorbed.
Yeah.
And it's probably isotonic, but
probably isotonic, but we're not sure. Okay, so this is important, right? You got to be sure about this stuff because they're gonna push you. They're gonna give you lots of different choices, and if you're not sure, it's gonna be really tough. So let's make this really simple. So this will always be isotonic. The reason is that you are absorbing water and solute at the same time. So water can follow the solute in this case, okay? Which means that if I take out solute, I'm going to have an equal amount of water loss, which means this is always going to be isotonic. So these questions that you guys get, they're going to try and trick you, but this is always going to be isotonic, no matter what. No matter if you give them diuretics, it doesn't matter. It's always going to be isotonic. Okay. Now let's talk about the descending portion. So what allows it to get more hypertonic as we go down? We talked about this last time. So I'm going to ask Lindsay, why does this become more hypertonic as we descend?
Down the thick descending limb?
Yeah.
Okay, because you are only permeable to water, and so your water is being reabsorbed, but your solids are staying in the lumen.
Perfect. Okay. And so Chris with a K, why would it become more hypertonic as we go down? But yes, it's only permeable to water, but so what? Like, why would water choose to leave? Because that's essentially what we're saying, right?
When we think about countercurrent multiplication, if we look at what the thick ascending limb does, it kicks out all the solute into the medulla.
Kind of. Let's put our nickel down. I want you to be precise.
Okay. So you can think about it as moving all the solutes into the medulla from the limb. So the purpose of that is that the entire medulla can become more salty, as it were, and then water from the descending limb will follow.
Yeah, that's great. That's fantastic. Does that make sense? I actually really like that explanation. So the thick ascending limb is basically salting the medulla. Never really thought about it that way, but that's true. We're salting the medulla, so water leaves from the descending limb. So as you get lower, it becomes more and more hypertonic, right? Now, so we posed this question last time. Are thiazides or loop diuretics more likely to predispose to hyponatremia, and why? Who can answer this question for me?
I think it's thiazides because it doesn't interfere with the countercurrent multiplication.
Okay, perfect. Can you explain? So thiazides because it doesn't. Okay, so what?
Actually, I never fully understood that. I just remember it from studying the PowerPoint, but I never understood it. So I wanted to hear it from this discussion.
Sure. Can someone explain it? I bet Chrissy. Yeah, I knew it. Let's hear it.
Okay, so thiazides work in the distal convoluted tubule.
Yep.
So their mechanism isn't involved with establishing the medullary gradient, but loop diuretics are. And so loop diuretics you would change the like degree with which you absorb salt and water to the same degree, so you don't risk like uncoupling that and getting less of a salt concentration.
Wait, uncoupling what?
Um,
The last part.
the salt and water reabsorption.
Okay.
In the way that like water always follows salt,
Uh-huh.
you keep that ratio like stable with.
Ratio stable. Okay.
Whereas with loop diuretics, you would block the NAKCl transporters, and so you would mess up that ability to concentrate urine.
Yeah, that's pretty good. So does that make sense? So the reason why I like these sorts of questions, okay, so if you can understand the answer to this question, it means that you definitely understand countercurrent multiplication. Like you have to understand countercurrent multiplication to explain the answer to which of the two thiazides or furosemide are going to give you hyponatremia. Okay, so
Can I hear the explanation again, please? Sorry.
Yeah. So let me explain. So in a very big picture sense, the entire basis of countercurrent multiplication is the fact that in the ascending limb, only salt moves and water can't, right? It's permeable to solute, but not water. And in the descending limb, it's only permeable to water and not solute, right? So those facts, coupled with the fact that you have a sodium-potassium 2-chloride channel, that sets up all of countercurrent multiplication. If one of those things were not to be true, you couldn't have it. So in this case, you're blocking the sodium potassium. So in the case of furosemide, if you block the sodium potassium 2-chloride channel, they could easily ask you this question. They could ask you, what would be the osmolarity in the proximal tubule, in the distal convoluted tubule, and in the distal collecting duct? They could ask you that question. That would be a fair question. So who wants to give a stab at that? Because that's tough. This is like we're talking like 230, 240 level question on step 1. If you could answer this, like most people wouldn't be able to answer that because they wouldn't have the depth of knowledge to be able to answer that. So who wants to give that a shot?
Can you repeat the question?
So the question is, in the case of giving someone furosemide, what would be the osmolarity in the proximal tubule, in the juxtaglomerular apparatus, and in the collecting duct?
So the proximal tubule is always isosmotic.
Always isotonic. Good. So you can eliminate 2/3 of the answers just based on that. Okay.
And wait, osmolarity in the tubules or in the blood?
So let's say the distal convoluted tubule and in the collecting duct.
Okay.
The collecting duct catheter would be hypertonic.
Hypertonic? Okay, why?
Because the point of furosemide is to remove water. If you use water, you remove solutes. And if you're blocking the sodium potassium chloride channel, there will be less ions coming to the medulla. So they're going to stay inside of the tubule. So for me, it makes sense that it's hypertonic because a lot of solutes are staying inside of the tubule.
That is like the kind of reasoning that they're going to prey on. The reason being, so again, remember, you have to remember the mechanism by which you actually concentrate urine, okay? The way that you concentrate urine isn't that you stop reabsorbing solute. The way that you concentrate urine is that you reabsorb free water. So having more solute actually has no bearing on the osmolarity. Should have no bearing on the osmolarity. So that's not true. Who wants to give it a shot?
I can try. So we said that in the presence of furosemide, right? So we're saying that the proximal tubule is isotonic. I think that the distal tubule will be more concentrated than in the picture, and the collecting, because you have blocked your sodium potassium 2-chloride channel, and so they don't have an opportunity to leave. So
is it isotonic, hypertonic? So let's presume that it was completely blocked. Let's say that you poisoned all of the sodium potassium 2-chloride channels. Would it be hypertonic, isotonic, or hypotonic in the distal convoluted tubule compared to the proximal tubule?
Hypertonic, right?
No, it's actually isotonic everywhere, right? Now, someone tell me why. Someone tell me, why would it be, how about MJ? MJ usually likes to answer these kinds of questions. So MJ, why would it be isotonic everywhere? So again, they could easily, so I want you guys to see the kinds of reasoning you need to be able to do for your exam. So yes, everyone, by the time that they take their exam, hopefully will know that this is isotonic, or at least in this group. I hope that all of you guys will know that. What will differentiate students after that point is when they start to manipulate things. So like, just like the question of in nephrogenic diabetes insipidus, what would be the osmolarity here and the osmolarity here? They could also say, in the case of furosemide or giving lots of furosemide, what would the osmolarity be here or here? That's a very fair question. But these are the kinds of questions that you need to be able to answer if you want to have a chance of breaking like 230, 240. MJ, what do you think?
I cannot figure out, but I'm guessing maybe
That's because during the DI, you lose
No,
too
we're not
much.
talking about diabetes insipidus. We're talking about furosemide. We're talking about furosemide.
Would it be because you would stop the water getting reabsorbed?
You'd stop. Well, what do you mean? You'd stop the water getting reabsorbed.
So when the salt leaves in the descending loop of Henle, that's when we're setting up our concentration gradient. And as the salt leaves, then the water leaves, and we pretty much lose like the same amount of salt and water.
What do you mean? We lose the same amount of salt and water. Oh, you mean in the
completion of the loop.
You're talking about into the medulla, like in the actual interstitium itself. Sure. Okay.
So the osmolarity is going to be the same, because if you block the NAK2Cl channel, you're not going to have the same concentration gradient set up whereby the water leaves. So the sodium and like all of those ions are going to stay in the nephron and in the tubule, but the water is also going to stay. So the osmolarity, like the ratio, is going to be the same.
I think my guess is that if anyone didn't follow it, it would be because of what you said in the last part. The salt and the water, the ratio is going to stay the same. But let me try and help. So I think what Sarah's trying to say is that so you're not able to salt the medulla anymore, right? If you block the ability to have the sodium potassium true chloride channels, you can't put salts in the medulla, in the medullary interstitium, which means there's no driving force for the water to leave in the first place. Do you guys follow? Right? There should be no reason, right? If this didn't happen, if I couldn't move salt in here, there's no reason for this to become more hypertonic. Does that make sense? So if I can't move salt into the interstitium, then I'm not creating a gradient anywhere. Do you guys follow?
Yes. Right.
Yeah. So really, this should all be isotonic. If I can't move, if I've poisoned all of my sodium potassium true chloride channels, it'd be impossible to move salt. And so remember, it's this gradient, the medullary interstitial gradient, that allows for you to reabsorb water in the first place, and also allows you to create more hypotonic fluid in the distal convoluted tubule. Does that make sense?
Can I ask you a question? So are we talking about it's isotonic compared to the medulla, or isotonic compared to the concentrations in a regularly functioning countercurrent?
No. So it'd be really confusing to say relative to regularly functioning countercurrent. No. Like relative to the body, relative to the proximal tubule, relative to the serum. Remember, everywhere in your body is isotonic. The only part of your body that's not isotonic is in basically the renal medulla and this part right here, right?
Get to the distal convoluted tubule and the NaCl channel is working there?
That's a good question. So I think, that's a good question. I don't think that, because I think that water and salt both go together. So I think in that case, it's an isotonic shift there as well. So I don't think it shouldn't, right? Because this is what sets the osmolarity. This is what sets the gradient. So that shouldn't matter because it's also soluble to water, pretty sure. Because again, this is the rationale for why furosemide, you can't become hyponatremic. Why? Why can't you become hyponatremic if you give someone furosemide, at least in theory? In practice, you probably could, because this would never become perfect. You could never perfectly block the sodium potassium true chloride channels. So you would always still probably have a little bit of a gradient. But if you could perfectly block the sodium potassium true chloride channels, you should not be able to become hyponatremic. Why? Mo, what do you think? Mo was telling me earlier that he knows all the answers to all these questions. We're going to have him explain.
It's because they get to a point where the gradient shifts against the score.
The gradient shifts? What do you mean?
Even with furosemide, you still need like more of like concentration in order to hit smooth. But if you keep getting rid of like sodium, eventually it'll just stop and then it'll switch. That makes sense. So
I'm not sure. I did not follow that actually. What gradient would shift? I don't understand. Okay, let me explain it to you guys. So basically, the reason is that if you don't have remember, the gradient is the entire reason why you can absorb free water. No gradient, no free water reabsorption. Okay, do you guys follow? So the reasoning goes something like I block the sodium potassium true chloride channel, which causes me to lose the countercurrent multiplication, which leads to loss of ability to absorb free water, right? So if I can't absorb free water, then I can't dilute my serum to the point where I'm hypernatremic. Does that make sense? I can't make my serum have a lesser osmolarity because I don't have the ability. I can't reabsorb free water. Does that make sense?
Yes.
Cool. Okay, perfect. So
sorry, can you go back to that picture of the nephron?
Sure.
I just want to make sure that I'm understanding. Okay, so in the thick ascending limb, that's where you're blocking the NAK
Correct.
CL channels. And so since you're blocking them, you're not concentrating this middle medulla part. And so with the lack of that concentration gradient here, you're affecting the way free water moves in the descending limb.
Perfect. Yeah, because remember, all I'm doing when I'm doing ADH is I'm putting water channels there. The water could, in theory, move into the tubule, right? It doesn't have to be absorbed out. The only reason that it's absorbed out is because there's a concentration gradient where the medulla is more salty than the tubular fluid. The only reason why having ADH put aquaporins in, the only reason why water is actually moving out is because you have a high concentration of solute in the medullary interstitium and not in the collecting tubule, collecting duct.
So going back, so for the effect loop diuretics on osmolarity in the proximal tubule, distal convoluted tubule, and collecting ducts. So proximal tubule is isoosmotic, distal convoluted tubule is isoosmotic. And then in the collecting ducts, since you can't move the water back out, you would be hypo.
No, it'd be isotonic. Also isotonic, right?
There was no difference.
Because there's no difference. You can't concentrate or dilute your urine along this entire path. So it should be the same osmolarity everywhere.
Okay.
Does that make sense?
Yeah.
Cool. But you can see how this is like exactly the kind of question that you're going to see on the day of your test. So it happens every time. I get emails. So one of you guys, I won't say who, but one of you guys is taking their test like right now as we speak. One of the people in the group. And I guarantee right now, this person is seeing questions that they've never seen before, like never prepared for. That's true of everyone, okay? And so the people that do well on the exam are the ones that are able to take what they've learned and adapt it to novel situations. So like the question of in diabetes insipidus, nephrogenic diabetes insipidus, or any sort of insipidus, what would the osmolarity be at the different stages, right? Or in the case of a complete loss of the sodium potassium trichloride channel, what would be the osmolarity at the different parts? Those are fair game, even though you've probably never ever seen those questions on UWorld and probably never will. Does that make sense? You need to be able to manipulate it.
I understand that it's fair game for step one. Is that kind of stuff clinically relevant if they become an internist or something?
To nephrologists, yeah. I don't know that this particular fact. So countercurrent multiplication and understanding the ability to concentrate urine, yes, absolutely. That is very, very relevant. Like whether someone's like hyponatremia is because like you'll know what kind of drugs they're taking, so probably not. Like you would never be like, oh, they're hyponatremic, so it can't be furosemide poisoning. So not in that respect, no.
Okay, thanks.
Okay, so let's talk briefly about azotemias. We didn't talk about this last time, did we? I'm just going to give you some numbers that you should know. So prerenal azotemia. First of all, what does prerenal azotemia even mean? Fayaz, you haven't said anything. So what do you think?
High creatine, high BUN in the blood, right?
But what does it mean? So you're telling me like numbers, but I'm saying like what physiologically does that mean?
The kidney cannot dilute or get rid of the BUN and the creatine.
I don't know about that. So in general, so kidney failure, like how do we define kidney failure, Vibhu?
Kidney failure, inability to prevent like larger molecules like proteins from going into your urine.
It's actually not how we define kidney failure. Can someone help?
Elevated BUN and creatinine.
Yeah, really it's just elevated creatinine. So why? What is it? But what does that indicate? What are we using creatinine as a proxy for? GFR. So it's filtration. So kidney failure is defined as a filtration problem, right? So if the kidney's filtering less, it means that you are in kidney failure, or at least you have decreased renal function. Okay, so the difference between prerenal azotemia and intrarenal azotemia is that prerenal azotemia, it means that GFR is down because of renal blood flow down. But the glomerulus itself, like the kidney itself, would function fine if blood flow were okay. That's basically what prerenal azotemia is. What does intrarenal azotemia mean?
So if it's intrarenal, then there's going to be a problem with your membrane where you're letting ions through. And
it's a problem with the kidney itself.
Right.
Which leads to the GFR down. So in other words, if I were to restore blood flow to the kidney, if I were to increase blood flow to the kidney, it wouldn't matter. I still wouldn't be able to filter. Okay. So can someone explain to me why would a prerenal azotemia have a low FeNa? Why does that make sense? Let's do a Shama.
You're getting just less blood to the kidney. That means you're getting less reabsorption of sodium just because there's less going to the kidney.
Wait, what does FeNa mean?
excretion of sodium.
Yeah, exactly. It's actually that you're excreting less sodium. So you actually be absorbing more, right? Because if you think about the actual equation, it's technically clearance of sodium over clearance of creatinine. I think it's clearance of creatinine over clearance of sodium. But anyways, of the total amount that's filtered out, how much is actually excreted? So if it's less than 1%, it means you're reabsorbing a lot of sodium. Okay, so why would that make sense? In a prerenal azotemia, why would your FeNa be low? Chris with a K.
I don't know.
Okay, can someone help? Mo, what do you think? Go ahead.
So you're getting less blood flow to the kidney. So your kidney senses that and activates the RAS system. And so you'd start reabsorbing more sodium.
Yeah, exactly. The basis of the way that you set your intravascular volume is the amount of sodium. Remember we talked about in the beginning, sodium is there to set your extracellular fluid concentration. It's to set the amount of extracellular fluid you have. So the more sodium you have, the more extracellular fluid. The more extracellular fluid, the more intravascular volume. So the whole point here is that sodium sets extracellular fluid. So if you reabsorb sodium, it should lead to intravascular. That's the whole point. Okay. Now, why would in the case of intrarenal azotemia, why would the FeNa be up, or would the urine sodium be up, Shama?
Because you can't reabsorb the sodium easily now because there's dysfunction with the actual glomerulus this time.
Yeah, exactly. If there's a problem with the kidney, if it is with the kidney itself, you're going to have problems all along it. So you won't be able to absorb nearly as much sodium. Perfect. Okay. So this is critical for you guys to understand, right? I want you guys to make sense of it. But again, you have to understand this for your test. Okay. All right. So let's kind of change gears. We're going to talk about hypersensitivity reactions. Okay, so what does a type 1 hypersensitivity reaction actually mean, Chrissy?
So type 1 is when you encounter an allergen and you produce IgE in response to it. And those IgEs go and attach to your mast cells so that the next time you encounter that allergen, your mast cells are hypersensitized, and then the antigen will bind to the IgE and cause mast cell degranulation.
Yeah, perfect. So basically a systemic reaction that's mediated by IgE. But yeah, perfect. You walked through the mechanism quite well. That was good. How about a type 2? What's the difference between a type 2 and a type 3 hypersensitivity reaction? Chris with a K.
For a type 2 reaction, you have the antibody bind to a fixed antigen. That's going to be relevant later when we talk about linear IF and lumpy bumpy. And then for type 3, you have the antibody antigen complexes floating around. They bind together and they float around in your body. They deposit in your kidney and your skin and the other one. Anyway, they deposit in the body.
Perfect. Yeah, exactly. So one is a bind to a fixed antigen versus in type 3, it's a complex antigen antibody complex. Perfect. How about a type 4, Maria?
4 is a late sensitivity reaction, so it's a T cell.
Yeah, perfect. This is relevant because they're going to ask this question of you give someone a PPD, and if you were to biopsy someone that had a positive PPD, what would you see? What would be the predominant cell that you would see? What's the answer?
T cells.
Well, yeah, T cells or macrophages. It's one of those two. It's going to be one of the two. Actually, probably macrophages would be the correct answer because they love macrophages on the test. We'll talk about that in a future session about how to spot macrophages and how it can help you answer questions. But the guy, Henry Sanchez, that writes questions for the exam, he talked about the importance of understanding macrophages. So we'll talk about that. Okay, so good pastures. So good pastures, important things to know. So it's type 2 hypersensitivity. So we're going to talk briefly about trying to use your understanding of the hypersensitivity reactions to understand why they look the way that they do. So in good pastures, it's an antiglomerular basement membrane, okay? Antibody. It's a type what? Type 2 or type 3?
Type 2.
Type 2. And why is it type 2?
Because it's fixed.
Yeah, it's fixed, right? The antigen, the glomerular basement membrane isn't floating around. So it's a fixed antigen. So you have to know how it presents. So renal failure, so RPGN, basically, rapidly progressive glomerulonephritis. It's very similar in presentation to Wegener's. How do you differentiate it with Wegener's?
The lungs.
Yes. What do you mean the lung?
Upper respiration.
Yeah. So bloody nose is something that you would see with Wegener's, but you shouldn't really see it with good pastures. That, and one is ANCA mediated and one is the glomerular basement membrane. And then Wegener's is negative IF. So we'll talk about that in a sec, but keep that in the back of your mind. Okay. So if we were to stain good pastures if you were to stain the kidneys in someone who's good pastures, what would it look like? Would it look lumpy, bumpy, or linear, and why?
Linear.
Linear. Okay, so why would it look linear?
Along the basement.
Yeah. So basically, you have antibodies that are going against the entire basement membrane. It's hitting the entire basement membrane, so it's going to be evenly distributed, right? Not lumpy, bumpy. Okay. In general, if you see a linear pattern, you should think good pastures. Like there's nothing else that looks like this, at least for step 1. Okay. So how about lumpy, bumpy? If something is lumpy, bumpy, what do we know that it is and why?
It's definitely lymphatic.
Yeah. Post-strap or something. So what does it tell us? Why would it be lumpy, bumpy? Why would that make sense?
Because it's type 3 and they're just depositing anywhere.
Yeah,
So
exactly.
it's not like uniform. It's just going to be,
Perfect. Yeah. So if it's a type 3 hypersensitivity reaction, you have these balls of antigen antibodies floating around. Okay, perfect. Who can explain to me why is there in post-immune glomerulonephritis, why does it make sense that well, first of all, what does it mean if it's post-immune?
Means that we don't have antibodies to detect.
Yeah, there's no antibodies that you can detect. And why? Based on the pathophysiology, why would that make sense, Maria?
I actually never thought about that before. I just learned it that way.
So you have to know this fact for step 1, right? The fact that if you were to stain someone's kidneys for antibodies that had Wegener's, you wouldn't see anything. You wouldn't see a fluorescent pattern. You wouldn't see lumpy, bumpy. You wouldn't see linear. So the question is why? Who can explain?
I can
Chris.
try.
Sure, please.
So when we think of posse-immune, it's kind of like a lack of an immunity because it have the prefix posse in there. And the antibodies, instead of doing what we think they would do in the other kidney problems, they would activate neutrophils and cause organ damage, and it would manifest in that manner.
So that was not bad. A little vague, but not bad. So it's not that you have lack of immunity. You still have the immune response. The point is that you have this, right? So there's some sort of ANCA antigen. So it's some sort of cytoplasmic antigen. And so you have an antibody against the neutrophil. The point is that that antibody, when you get enough of those antibodies, you can actually activate those neutrophils. It's sort of like having a bunch of grenades. Like your neutrophils are sort of like grenades, and the antibodies are activating those grenades. So you don't really see the evidence of the antibodies there because the antibodies are gone because they've already done their job. Plus, they probably weren't in a large enough concentration to be stained. That would be my guess for why you don't see them. But the point is that you don't have, it's not the antibodies and the antigens they are not directly affecting the kidney. They're affecting the neutrophils, which are affecting the kidney. Does that make sense? Cool. Okay, perfect.
So do some people just have more ANCA and that's why they get these?
I don't know. I don't know that it's understood why. I mean, it's all autoimmune disease, right? Like, why do some people get like autoimmune disease? I don't know. That's like an open question in medicine. What is the pathophysiology of most autoimmune diseases? So I don't know. My guess is that falls under the category of no one knows yet, rather than we in this group just don't know. But has anyone ever told you guys why it's hypothesized that women in childbearing years have a greater amount of like autoimmune disease or like weird antibodies like lupus? So
level increases.
Because what?
At estrogen level.
Estrogen, maybe. So the idea. So again, there are holes in this theory, but this is something that maybe will help you remember that like it's women of childbearing years that are at greatest risk for autoimmune disease, particularly things like lupus. The idea is that because of menses, right? Like all cell death in the body, or at least the vast majority of cell death, is apoptotic, right? Planned, like clean, like cell death. In the case of menstruation, it's different. The cells are actually like, I would assume it's like necrosis, right? Like you're losing the effects of the estrogen. But the point is that you have spillage of all of this like cells and cell contents. And so the idea would be that your body suddenly recognizes these like intracellular elements and then goes after them with immune responses. It kind of makes sense in the sense that how else can you explain that you would have antibodies against double-stranded DNA, right? Or like some of these intracellular elements that you would never expect the body to ever see. There are holes in that theory. But again, the thing I want you to remember is it happens in women of childbearing age.
Can I say something? Last year, I had one class, and it was about autoimmune diseases. And the doctor said that women that had Raynaud's or Kraft syndrome were less likely to develop acute cases of that disease when they were pregnant.
Interesting. Huh.
So
why was that hypothesized?
For example, that specific doctor, she had Raynaud's, and she said that she accidentally got pregnant when she was like 24, 25, and that during that time and a lot of time afterwards, she didn't have any exacerbation of Raynaud's.
Interesting. Huh. That, I mean, again, so that would lend, yeah, I wonder if that's true of other autoimmune diseases as well. That when you're not menstruating, I don't know. It's an interesting idea, right? They will probably never test you on that mechanism per se, but they will definitely, you definitely need to recognize who are the key populations that are going to get autoimmune diseases, and this will help.
Yes.
Okay, perfect.
Another theory is about the estrogen may reduce the apoptosis of self-reactive B cells. That's why there was another reason for the disease come up during
Say that one more time.
the estrogen level increases may reduce the apoptosis of self-reactive B cells.
Reduce self-reacting.
Reduce apoptosis
Oh, I see.
of reactive B cells.
Huh, interesting. Oh, I see. So you're saying that women that are like menstruating or have higher levels of estrogen are more, oh, interesting, are less likely to kill the bad B cells that could attack.
Yes.
Huh,
Yes.
that's kind of cool. I want to talk briefly about acute tubular necrosis and nephritic versus nephrotic syndrome. And then I want to go through questions. So I wanted to spend actually as much of this session as possible on questions because a lot of you guys are close to your tests. And I think part of it is knowledge, but I think part of it is like you guys really need to work on is going through questions and analyzing them and thinking them through in the 4 steps. So I want to talk about that. So briefly, let's talk about nephritic versus nephrotic syndrome. Nephrotic syndrome, I think the easiest way to think about nephrotic syndrome is it's an exclusion problem. This would be the pathogenesis to presentation question that I would have you guys put in your cards. But if you think about it, it's a problem of excluding proteins. So proteins leak through the glomerular basement membrane very easily. So because of this, this explains a lot of this sort of, I guess, side effects. So like you lose albumin, so you get anasarca. Anasarca is just total body edema. You lose antithrombin 3, so it's odd, but you're actually hypercoagulable, even though you lose coagulation factors and your PTT is very high. So this is weird, but these are things that you can use to identify nephrotic syndrome or things that they may ask you on your test. And you also lose immunoglobulin, so you're immunodeficient. But the picture I want you to have for nephrotic syndrome is you're just losing protein. It's an exclusion problem. You can't exclude proteins from your urine. Nephritic syndrome is different. Nephritic syndrome is if you think of the kidney or the nephrons as a bunch of things that are filtering stuff, because we said kidney failure is when you can't filter stuff. Nephritic syndrome is really just you can't filter stuff. So it's basically like kidney failure. So all of the things that you think of for kidney failure are going to be true for nephritic syndrome. So you're going to get azotemia, you're going to get oliguria because things aren't filtering through and you're not making urine, and you're going to get hypertensive. Why would you get hypertensive? Why would that make sense? Sarah, why would that make sense?
So if you're not filtering, for example, sodium through, you're going to have like hypernatremia and hypertension secondary to that.
Yeah, exactly. Because again, I love it. You talked about sodium, right? And sodium sets what again? The extracellular fluid volume. So sodium sets the extracellular fluid volume, which is setting our intravascular volume, because your intravascular volume is 1/4 of your extracellular fluid volume. Perfect. Okay, let's talk briefly about ATN, because it's going to show up in one of the questions. So in acute tubular necrosis, what's the most common cause of acute tubular necrosis on your test, right? When you take your test in a week and a half, what's going to be the lead up for acute tubular necrosis?
I think like it's the pre-renal problems, like hypertension.
Yeah, exactly. So why does that make sense?
If you don't have blood going to your kidneys, it's gonna like necrose.
Yeah, exactly, right? Ischemia causes death. Well, ischemia for long enough causes death in all organs, right? So in the case of prerenal azotemia, right, where you're not getting enough blood to the kidneys to allow filtration, you are having ischemia to those proximal tubular cells, and so they're gonna die. So that makes sense. So we said the most common cause is prolonged prerenal AKI. And then what's the key finding in the urine in ATN, and how do you make sense of this, Mo? What do you think?
I imagine it would be like low urine.
Nah, that's very non-specific. Prerenal azotemia will also give you low urine output, right? A bladder obstruction is also going to give you low urine output. Can someone give him a hand?
Yeah, so you'd find granular, like muddy casts.
Granular muddy casts. I love it. So this is something that if you didn't know, you should write down. This is one of those things that you should like tattoo on your wrist so that they can't like take it away from you. Like this you can bank on it being on your test. Okay, so why is it granular muddy casts? Why does that make sense?
So you're having necrosis of the cells in the tubules, and so
Where in the tubules? This is also a step 1 question. Where in the tubules are you going to get necrosis?
So it's the proximal and then thick ascending.
They're going to ask if it's possible. Yeah. And MJ, why does it make sense that it's in the proximal tubule? Like that would be particularly prone to it?
I think maybe that's because more solids pass through that, and it's the first place.
Yeah, exactly. It's where, like, if they ever ask you, like, where does the majority of absorption of X happen? 9 out of 10 times it's going to be the proximal tubule, meaning the majority of everything is absorbed in the proximal tubule, which means it's highly energetically active. So it needs a lot of ATP. So it makes sense that that would be the most sensitive to ischemia. Okay, so those cells die. And so, wait, why do I get muddy brown casts?
So the cells die and they get sloughed off into the tubules, and they just take the shape of the tubules, and then they get pushed out and they still look like that.
Exactly. So when I was younger, we had this laundry chute in my room that was like the only laundry chute to the basement. And so I thought I would be clever and try to put like all of my laundry down in one go. So what happened is it got blocked up, as you would imagine. But then like eventually, as I was able to get the clothes down, like they, for a brief period of time, took the shape of my laundry chute. So that's essentially what's happening in ATN, right? The cells are sloughed off, just like my clothes, my dirty clothes, and then they get stuck in the tubule. So they block anything else from going down. So that's why you're oliguric. And then eventually when they pass, they take the shape of the tubule, just like my clothes took the shape of my laundry chute. Does that make sense? So they're going to sometimes ask about the different phases of ATN. And Chris, to your point, this is actually very clinically relevant because you need to be aware of this, because when people have ischemic ATN, they're going to end up peeing a ton, and you need to know why. Okay, in early ATN, it's the oliguric phase. So why would it make sense that you would be oliguric? Well, we already talked. We already said you're oliguric because the tubules are blocked because you've got those dead proximal tubular cells that are clogging them, just like in my laundry chute. Okay, so your potassium is going to be high because you can't excrete any potassium, and you're going to be hypertensive because, like Sarah was saying, you're not going to be able to get rid of any sodium either. Okay, so the one that's difficult to understand is the late ATN, or the non-oliguric phase. So you're going to be polyuric and you're going to have low potassium. So can someone tell me why that would make sense that you actually, it's odd, but in ATN, you're like at some point you're going to start peeing out a ton. So how about Lindsay? Can you tell me why it would make sense that you're suddenly like peeing out a ton and your potassium's low?
I think that it may be in response to trying to deal with hypernatremia.
Oh, so you think it's a response? Not really a response so much. Can someone help?
Can I?
Please.
Yeah. So let me go with your laundry chute analogy.
I love it.
You block your laundry chute, and so your attempt to solve it is you make 3 other laundry chutes, and then all of a sudden your original laundry chute unclogs. So now you have 4 laundry chutes all shooting out.
That's nice, but you don't actually make more nephrons. So it's actually not that. So the reason is because you're making more, you're regenerating the cells, right? So it's sort of like, so we're gonna have to get rid of the laundry chute analogy at this point because it's not gonna help you understand it. So the reason is that the cells themselves, like, so a mature proximal tubular cell, if it's like at the top of its game, it's gonna be able to reabsorb a ton of stuff, potassium, other solutes. Now, if it's an immature cell, would you believe me that it's not going to be able to reabsorb as well as a mature cell?
Mm-hmm.
Yeah, exactly. This is the same. Yeah, this is the same principle for like why kids, when they have like a GI infection and their GI tract like sloughs off, this is why they'll still have watery diarrhea for a while, even if the organism's been cleared, because the cells themselves are immature. So in this case, the proximal tubular cells are immature, so they can't reabsorb stuff as well. So because they can't reabsorb stuff as well, they can't reabsorb solute, so you're going to lose water because water follows.
Alec, I just love these explanations because these answers me a huge question my customer asked me.
Perfect. I love it. That's fantastic. I'm really glad that you said that. Yeah, because right, the explanation, like you can make sense of all of this. The reason why I want you guys to see as many explanations like this as possible is because I want you to see that it's possible to learn all of medicine like this. So, but you're also going to lose, so you're going to lose solutes, you're going to lose potassium. Make sense? Okay. We're going to talk briefly about aldosterone escape. So what is aldosterone escape?
So when you have a lot of fluid in your system, like high blood volume, your atria sends the stretch, and then they secrete ANP, which helps nature
Yeah. In other words, natriuresis. So it's net. So it's funny. My wife is Korean, but she studied in Austria. So she speaks German because she studied violin in Austria for like 5 years. There's like a handful of things that she says that are kind of odd. One of those things is natrium. So like we were talking about something and I was like, oh, it's like really salty. She's like, yeah, well, the natrium is really high. I was like, excuse me? Like, I don't understand what you just said. She obviously meant sodium, but I guess in German they say natrium or something, some equivalent. So natriuresis means like sodium loss. Does that make sense? That's why I brought that up, because like we still use the root. Okay, so the reason why we're going to talk about aldosterone escape is because the reason why it even matters, because like I was like, why would we even talk about this? So the idea is that in the case of primary hyperaldosteronism, do you get a lot of edema? No, you don't. You don't get a lot of edema. And it's weird, right? Because you'll present with hypertension. So you're presenting with signs of high intravascular volume, but it's not like you're absorbing so much sodium that you're expanding your extracellular fluid that you're getting edema, right? It's odd, right? Like, why, right? Your aldosterone is high. Why wouldn't you have edema? It's kind of weird, because in secondary hyperaldosteronism, like in heart failure or in cases where the kidney is hyperactive because you have renal hypoperfusion, you do get a lot of edema, right? Heart failure, they present with tons of edema by this mechanism because you have high aldosterone, you have high RAS because you're reabsorbing fluid. So it's odd. This is the odd duck, okay? And so no one really understands fully why. In one case you do have edema, in the other case you don't, but it's thought to be at least mediated in part by ANP. So ANP is released, as Chrissy has sort of hinted at, because of stretch of the atrium. So when the atrium stretches, you release ANP, and ANP causes you to pee out salt more, natriuresis. So that it counteracts the amount of salt that you're reabsorbing with the aldosterone. You're peeing out that salt. So you're at you reach a steady state. Cool. So I get this question a lot. I wanted to just talk about it briefly to all of you guys because this comes up a lot. So what is aldosterone escape? It is the mechanism that's posited for why in primary hyperaldosteronism you don't have a lot of edema. Okay, perfect.
You just learned how to see pathophysiology patterns in internal medicine. Now you need the right practice system to turn this knowledge into high scores. In my UWorld Complete Guide, I'll show you the exact phase-by-phase approach that takes you from basic question practice to 260 plus mastery.